Good morning, everyone. Let me take this opportunity to welcome you to our national seminar and please accept greeting from us here at the Jamaica Enrolled Nurses Association. This morning, we have a lineup for you the entire day, and we are running a bit late, so we're not going to be too lengthy. So this morning, without further ado, I'm going to ask Nurse Parchment to just take us into our devotional exercise.
Hello, you're hearing me? You're hearing me, nurse?
Yes, I'm hearing you, Nurse Parchment. Go ahead.
Okay, thank you. Seeing that we are late, I'm not going to go through a lot of things. We were just going to pray. We will give God thanks that we are alive this morning and that He has given us this opportunity to meet this day that is His, and we will rejoice and be glad in it. Just a word to say, um, Saint Matthew 26 and 73 to 75, I will not read, but I will tell you, and you can read on your own. Yes, Peter, the Lord prayed for Peter because he said that he would deny him. Peter didn't believe. Peter thought that he loved the Lord with all his heart, and he would even go to the cross, he would even die with him. But then Peter's faith in Christ was tested. And when persons came and said, you know the man, you were with him, he denied it. And he denied it 3 times. And he remembered at the end of the third person saying it to him that the Lord told him before that he would deny him 3 times. Saying this to us all we know, our faith in the Lord, our faith in our association, our faith in our goals will be tested. And no matter what it is, it depends on how we behave during our test. And that will determine how much we will get, how much grade we will get. And what I'm saying this morning is our faith as nurses on the wards, at home, wherever we are, our faith will be tested. However, it depends on our attitude during the test. And I'm encouraging all of us to make sure we pass our test and passed it well. Allow ourselves to know that we are ambassadors for the Lord, and wherever we go, whatever we do, let us remember that we represent, and we represent ourselves, we represent the Lord, we represent our association. And I pray today that all of us will continue to work hard and do our best because we have a goal and we are going somewhere. So we're going to pray and ask the Lord to be with us this morning. Let us pray. Father, in the name of Jesus, we come to you giving you thanks that we are alive. Thank you for clothing us in our right minds. We are alive this morning, all because of you. Father, we know that you are our creator and our Lord. And we pray that as we make our presentations today, we pray, Lord God, that you'll be with us. Help us that whatever is done will be done in honor and glory of your name. Bless every presenter. Bless every person who is on this platform this morning. Bless the technical team and our moderator. Bless our president and everyone involved. We pray that our minds will stay on you and you will get every glory. Bless and sanctify our hearts. Strengthen those who are weak. Supply our needs according to your riches in glory, and let your will be done in our hearts. We give you every praise and every honor that is due unto your name. In Jesus' name we pray. Amen. The Lord bless you, my sisters and brothers. I pray that today will be a blessing in Jesus' name. Oh, Jesus.
Thank you, Nurse Francis Parchment, and we sure at this time I'm just going to do the welcome presenters who have accepted the anniversary celebration. And to me, we're not charging for the seminar. To everyone, whether you're joining, get someone to subscribe to our YouTube channel, Jamaica Enrolled Nurses Association. You can find us on YouTube. And without any further ado, I am anticipating that our Deputy Chief Nurse, Miss Juliet Mason Quarry, should be on. Welcome, ma'am. Welcome to all the other persons who are here. And it's a pleasure to have you all participating in this, our conference, our seminar. And our seminar today is sponsored by Orion Insurance Brokers and Industrial Life Services. They have goodies in stores, so guys, sit back, relax, and you have a wonderful day. And without further ado, I now present to you our moderator for this morning session. She is the first vice president of the Jamaica Enrolled Nurses Association, and she's also a member of the board of the Nursing Council of Jamaica, and she works at Spanish Town Hospital. Without any further ado, I now present to you our
Good morning, everyone. I'm so sorry. I sincerely apologize for this technical difficulty here. Suddenly, the camera just froze. All right. So, without further ado, let me just extend further welcome to all my colleagues and friends who are online with us today. And I will go straight into our first presentation topic, disadvantages of patients' medication. And so this will be done by Mrs. Michelle Douglas Shaw. She's a clinical pharmacist at the Mandeville Regional Hospital. So please help me welcome Miss Michelle Douglas Shaw. I'm sure our technical person is allowing her in present. Miss Shaw.
Good morning,
So I'm
everyone.
gonna go on mute.
Okay, so good morning, everyone. I'm trusting that you're all hearing me well. And I don't mind the feedback at all if you're able
Yes,
to.
good morning, Dr. Shaw. We're not hearing you.
You're not
so you can
hearing
just go
me?
ahead and I send you the permission to unmute yourself. So you can just click on that and we should be able to hear you.
Okay, so I have.
All right, I'm going to send you that again. So you should see the request.
I saw the request before, and I have unmuted.
Okay, I think we're hearing you now. Go ahead, speak again.
Okay, so I was just explaining that I have unmuted. So you're hearing me clearly now?
Yes, I'm hearing you. All right, great.
Wonderful.
Yes,
okay. Good
and I do
morning.
apologize for this, technical glitch.
Good morning, Dr. Shaw.
Good morning. That's quite understandable. I want to greet our moderator for today. And I also want to greet all the enrolled nurses who are on this morning and others who would have joined in for this day of learning. Okay, and when we have something good going, every now and again something comes to challenge it, but we're not going to be looking at that. We're going to be concentrating on using the opportunity that is being given to us today to come together and to sharpen ourselves and our skills. I am tasked with the what would I call it now? The pleasure of presenting on the disadvantages of altering patients' medications, right? I call it a pleasure this morning because I realize that every time we get an opportunity to make a presentation, it not only helps those that we're presenting to, but it also helps us. Today also happens to be a day of celebrating teachers. So when we get an opportunity to use our teaching skills, it's indeed a blessing. So if we have any teachers on this morning, I want to also celebrate with you because I know nurses wear a lot of hats. All right. So as we look at this topic this morning of the disadvantages of altering patients' medications, I want to make sure that we're all on the same page, right? So there was a case that I saw in which there was a nurse who was continually changing patients' medications. So she would just go ahead and change the dosing, change the timing at her pleasure. However, once when she did that and the patient, had to be rushed to the emergency room when she was confronted, she did not admit to changing anything. As a matter of fact, she just said that she would sometimes change the timing. And the patient was an elderly patient, so no one really believed when the patient said, no, that's what she would do. She's constantly changing my meds. When we're talking about altering patients' medications today, we're not talking about that kind of scenario, because you would have noted that the nurse would have even denied doing that, because she would realize that going ahead and changing an order that is made by a medical doctor without any consultations with that doctor and the approval to go ahead and do so is definitely a no-no. It's a no-no on the side of the nurses. It's a no-no on the side of pharmacists as well. So that's not what we're talking about. So what could we be talking about this morning? We're talking about the actual drug itself, altering the product and the disadvantages or the negative consequences that can follow from that, right? So we're just narrowing it down to that this morning. And why are we looking at this particular topic? I'm going to show you a case. All right, so this is a case summary of a 38-year-old woman who had multiple problems, and she was presented to the hospital in acute respiratory distress, diagnosed with acute pulmonary edema and pneumonia. The long and short of it is that she was prescribed some medications, right? And they were crushed and administered through a nasogastric tube. These medications include things like your oral hydralazine, labetalol, and nifedipine XL. All right, and the problem here was really the crushing of the nifedipine XL, right? Now the patient has the tube in, and in order to administer the drug, the nurse in this particular scenario had gone ahead and crushed it, right? But as a result of that, she developed worsening bradycardia with hypotension, and ultimately, unfortunately, this patient died, right? So the discussion here is that the administration of a crushed nifedipine XL tablet resulted in the patient's severe hypotension, as the release characteristics of the medication itself was destroyed. And we're going to go ahead to talking more about this as we get deeper into the presentation. So what are our objectives today? All right, we are going to review dosage forms. We are going to discuss the reasons for and the methods of altering dosage forms. We're going to explore disadvantages of altering medications and to discuss some recommendations regarding altering medications. So dosage forms, there are quite a few of these, right? We have solid, liquids, semi-solid forms of medications. And the reasons why drugs are placed in dosage forms is to allow for accuracy in dose, protection. So sometimes you have the tablets being coated. We have medications placed in ampules that are sealed. And of course, that would ensure that they are kept sterile. The protection from the gastric juices, of course, this one is understandable. The masking of taste and odor, all right, so that the medication can be palatable, all right. And we see others speaking to the placement of the drugs, sustained release medications, you know, for optimal drug action and for insertion, right? So we have various dosage forms. And of course, there's also the need not only of dosage forms in general, but you will have the same drug coming in various dosage forms. So a classic example would be like your paracetamol, right? So it comes as a tablet. We know it comes as a liquid, right? It comes in other forms as well. I am wondering if this is somewhat interactive, if I'll be able to talk to anyone. But if I can't even talk to you, I'm sure you can type. So I want to give you an opportunity to type. So we're talking about paracetamol. What other forms does it come in? I mentioned the liquid, the tablet. I want to make sure that you're hearing me and going along with me as well. So I'm giving you an opportunity now to tell me another form in which, or forms in which you could have gotten paracetamol or cetamol. Intravenous. Thank you so much, Jillian. Great. Karine, suppository, fine. All right, wonderful. So we don't necessarily see the IV form around much, but yes, it is available. And of course, it's suppository. So you have the same dosage, well, the same drug in various dosage forms. And this helps with convenience of handling, use, storage, stability, the whole thing of flexibility in the different strengths, provides expected therapeutic effect, and of course, for economic reasons as well. I'm going to also be asking if I could be prompted when we are about 15 minutes into the presentation, because I want to make sure that I'm keeping time. All right, thank you. So now that we have looked at the dosage forms, let's look at some reasons and methods, reasons for altering dosage forms and also methods of altering dosage forms. Now, the reasons. I have here a few, and we said that we're going to be discussing this, right? So I have a few reasons here. It's a common practice to use drugs in tablets formed by splitting or crushing them, right? That's the kind of alteration that we find. So the dosage form that I want to really concentrate a lot on this morning is that of your tablets or your capsules, right? Oral medications. And you find that in most instances, this is how your medications are given by the oral route. And it's with this particular route that you'll find the alterations being made to the actual drug itself. All right. Now, especially in geriatric and pediatric clinics, the whole altering of the medications by crushing and splitting it offers advantages such as providing appropriate dosing, saving costs, increasing compliance in patients who have difficulty swallowing. And as nurses, I think you can attest to this, right? That you're not seeing the changing of the slides? I'm seeing someone saying that. That's Alicia. So sorry about that, Alicia. Is there anyone else having that problem as well? All right, so the technical persons, what would you suggest that I do? Would you suggest that I stop sharing and reshare?
I'm sorry, Dr. Shaw. Could you repeat that?
All right, I saw a message from Alicia Dixon. She's saying that she's not seeing the changing of the slides.
Oh, yes. So, all right. Yes, stop share and restart the sharing. Yes, restart.
All right. Okay, so I'm going to stop and see if I can go ahead and share, and hopefully we'll take care. As I said, you know, these glitches will happen when we use these methods or systems to present, but we just have to try and work with it. Now, if I stay in this mode, I believe you'll be able to see when I'm changing the slides.
Well, okay, you can try changing the slide. Okay, it's changing now.
It is changing. All right.
Yeah, it's changing.
So I will go back to slide share and see, and you can then tell me whether or not you're still seeing it changing. All right?
Okay.
Are you seeing it?
All
And
right.
now I'm pushing tablets.
You're referring to full screen, share?
Yes, yes.
All right. So I'm not seeing it in full screen. So you can
All right,
so
so
go to,
let's go back out. All right, no problem. No
yes.
problem. So I will just stay in this mode. All right?
Okay, okay.
Okay, fine. So crushing tablets. We were just talking about, let me go back to the previous slide, reasons for altering. And even though I have these reasons here, I believe that there are other reasons that persons could give me as well, because this is not exhaustive at all, right? So I just have here providing appropriate dosing, saving cost, increasing compliance. Is there any other reason why, as a nurse, you might find it convenient to alter the medication? And remember, we're not saying altering the order, no, right? We're talking about the actual drug itself, having to say, oh no, can't work with this tablet as it is. I have to alter the medication. Think about it, because time is going. So I'm going to move on the list. All right. Okay, so crushing tablets. Okay, so the methods that have been used to crush tablets when persons find that, you know, they need to alter the dosing, you have what is called a mortar and pestle. All right, and these, for the most part, are very efficient at crushing your tablets. It's what we use routinely in the pharmacy setting to crush them. But I want us to realize that it must be recognized that there's a possibility of powder loss in actually using even a mortar and pestle to crush a tablet, right? So especially if you're working with a tablet and you're just crushing it to then go ahead and use it, you're going to find that you're definitely going to be having some loss, because there will be adhesion both to the pestle and to the mortar itself. All right. So an example is given here. About 25% of aspirin was lost when a mortar and pestle was used to crush the tablets prior to suspending it in water. Right? All right. All right. All right. So I see persons responding to the question I asked earlier. Thank you so much for your responses. Okay. Then there's a whole thing of splitting tablets as well, right? This is a method that arises from the need to change for optimizing your dosing, right? And we can understand this because let's say you only have a 40 milligram strength of a tablet, but you want to titrate the patient. You don't want to just start with 40 milligrams. And you might not even want to just start with even 20 milligrams, but 10, but all you have is the 40 milligram tablet. Here comes the dilemma where you have to try and now make up your mind as to how it is that you're going to be trying to give the dose that is required. So in these instances, there are lots of ways that persons seek to split tablets. Some tablets come scored, so there is an area in the tablet that's already indented, and so persons will go ahead and just break it. Some of them are easy to break. Others, you may use a knife. Some persons may even use a scissors, yes. And then there is what is called the tablet splitter, right, which is what we would be expecting that we would have in our settings as caregivers within institutions to use, all right? Nurses will tell me that they use the blades, right? To do the cutting, right? But the important thing is that with using the tablet splitters or in crushing or any of these other things that we're mentioning here, no, we're going to have to also be considering characteristics about the medications that we are trying to alter. All right. As it relates to the tablet splitter, it seems to be the most practical and safe method of actually using to split the tablets, right? Because with other things too, you may even end up doing injury to yourself or to something on which you have rested the medication. When splitting tablets either by hand or using a splitting device, it's not uncommon to obtain 2 tablet pieces that are not the same size. Not true, right? So when you finish splitting, you see one much bigger than the other. All right. And that can also cause variations in the dosings. I'm seeing where somebody said, what about opening a capsules? Yes, that happens too, right? The opening of capsules, which in essence is the altering of that form, right? Because the medication comes within the capsule, and just by opening it, you are altering that capsule. So yes, thank you for that. This just speaks more to the whole thing of splitting medications. And even though the drug that is mentioned here, cyclobenzaprine, is not one that we would be commonly seeing or even used to. Why I've chosen this tablet here is because it provides for us a case, right, in which this unscored tablets, right, was split using a kitchen knife, right, and a tablet splitter as well, all right? And it was found that the variation in weight of the 2 tablet pieces obtained was less with the tablet splitter than with the kitchen knife. And we're happy for that, right? Since professionally we are asked to really use the tablet splitter, right? They found variations of up to about 30% in the theoretical weight, which was obtained with the tablet splitter, while the variation of up to 50% was noted with the kitchen knife, right? So that was what was found. And interestingly, the smaller of the 2 tablet pieces would contain as little as 2.49 milligrams. Listen to that, 2.49, all right, about a quarter of the dose. So that would mean that if when you were through splitting, you gave the patient the smaller half, they're only getting about quarter of the dose at that time. All right. So this is really interesting to note. And with certain medications, this would be a definite no-no, right? Because you need to be so specific with the doses, especially with medications that have what we call a narrow therapeutic index, meaning that the difference between the dose that is efficacious and the dose that is toxic is very narrow. So you don't really have much wiggle room, all right, for error. I see someone placing in the chat too, what about valproic? All right, so I figure that's valproic acid. There is a kind of a gel formation, right, that the medication is actually in. So it is not now a powder within a capsule, right, but it's actually a gel or a liquid within that. And in those instances, there are ways too, right, of even injecting into that gel coating and pulling up the medication. So persons find various ways in which to alter in order to get what they want out of the medication. Here is just a picture of your splitter. All right, so we're coming down nicely. I haven't heard anybody tell me about 15 minutes yet being passed, but remember, I'm asking for a little indication as to where I'm at with time. Okay, so in terms of the third objective, which is to explore disadvantages of altering medications. All right, disadvantages of altering medications. And I'm seeing the questions, and if by the end we haven't touched some of those, I'll try and see if we can do it maybe in the question and answer area, or we'll provide some information after. All right. Okay, good. So you can always keep the questions coming. All right. Possible consequences of altering medications. We're going to be looking at that now. All right. Right away, you can be looking to affecting the patient's health, right? Unsafe changes in the vital signs sometimes are seen, hospitalization or prolonged hospitalization, death or serious injury, as in the case that I mentioned before with the nifedipine, right? Extended release, the mental anguish, disciplinary actions. And when we say mental anguish here, it's not just on the side of the patient or the caregiver, but mental anguish on the side of the health professional that finds themselves, you know, in this quandary where you're trying to help out by altering something, and it really ends up causing something detrimental to happen to a patient. All right. Of course, disciplinary action, increased healthcare costs, and lawsuits. And we cannot underemphasize lawsuits, right? Because as time rolls on, you find that our society, there was a time when we could look at abroad and say, boy, them can't sue people. But even in our society, no, we have to be so careful and vigilant, right? So we want to know that we don't find ourselves in these situations, not to mention the loss of our license to practice, all right? Other consequences, no, having to do with actually the product itself. We had mentioned before that dosage forms are made for certain reasons, right? And one of them is masking taste, making it, or odors. So making the product more acceptable, palatable. So when you go ahead and alter a medication, there's a possibility of you having no unacceptable taste. It tastes bitter, altering the absorption characteristics, because medications have what we call, you know, the pharmacokinetics, right? How the actual drug works. And so in terms of its absorption, its distribution, how it is metabolized, the excretion, all of various aspects can be altered, especially now in relation to absorption characteristics when you alter a product. All right, there is results in the medication's instability. All right, produce local irritant effects, cause failure to reach the site of action, produce occupational health and safety issues. And this one I really want you to pay attention to, right? Producing occupational health and safety issues. So it's not okay to just say that, okay, I need to administer this medication, and so I have to go ahead and push it. No, right? You really have to, if you're not sure, find out what's really happening with this. So even though it will be mentioned later on, I can just say from now, you know, if you're not sure, of course, we can always take up our smartphones and do our own research there on the spot. But because we are all working as a team, then you can always seek for the advice of your pharmacist, who is the expert on medications, right? And not only that, they have the information right there with them, because these products are coming out of the pharmacy. A lot of times when you get the drug, you're not getting the literature for the particular brand. So it makes much sense that you should be seeking the advice of a pharmacist, right? And what you find, so for example, as a pharmacist myself, I know that there are other pharmacists who would have more experience in the alterations of certain medications. So when we have to make suspensions for like children, I reach out to a colleague at Bustamante Hospital for Children, right? Because I want to know that I am on the right path, right? So we can all benefit from working with each other in relation to this. All right. Okay, moving right along. So various things were mentioned here. So we're just exploring what it is that we're talking about when we talk about the alterations affecting these parameters, right? So in relation to drug instability, we see there pushing an oral solid dosage form may have a negative impact on the stability of the drug substance. If an enteric coating, which protects a drug from the acidic environment in the stomach, right? If it's removed by crushing, then you realize what's going to happen when you take it inside, right? In vivo, right? So definitely you're going to have less than the desired outcomes with that medication, because not every medication you want to start being absorbed within the stomach itself, right? And so right there and then you're going to be having that issue. All right. Coatings are also added to oral solid dosage forms to protect the drugs from the effects of light, right? Which causes some medications to degrade. And here they have nifedipine as an example of one such drug. Okay. And you see nifedipine being featured a whole lot, right? Okay. Changes in pharmacokinetics and bioavailability, right? So I had alluded to this earlier, the pharmacokinetics, the absorption, distribution, metabolism, excretion of the medications, and how available it's going to be upon being ingested, right? So the splitting and crushing may produce changes in these parameters, and it can result in underdosing, all right? And such changes may be particularly important for drugs, and I had mentioned that before, with your narrow therapeutic indices like your phenytoin, digoxin. These are drugs that you really just don't play around, all right, with in terms of altering. I know a colleague of mine, Mrs. Naomi Foster, who, you know, she really specializes in pharmaceutics, had gone ahead and done a study in relation to the digoxin and how when you try to split it, you know, how the doses vary. And so you really have to be careful with these kind of medications. All right. Not to mention the risk to the worker is exposing themselves, because, you know, when you crush, when you split, yes, to some degree, but definitely when you crush, right? Basically, you are reducing the particle sizes, right? And so as you reduce the particle size, much more of an opportunity now for you to be inhaling that which you're crushing, right? And so definitely those drugs that may be carcinogenic and so on, you have to realize that this is not just something that you can take up and say, I'm just going to crush it and use. No, no, no. All right. So even in the trying to make suspensions from medications within the pharmacy setting, we would have a hood that we work under. All right. So that the possibilities of us inhaling the medication that is reduced, drastically reduced, because of the fact that you have a fume hood that's taking that away from you. All right. Similarly, preparations containing hormones, you have to be concerned about those as well. It should be noted that the effects of many drugs when inhaled is largely unknown. So it's not as if, oh, we have this study, so you're going to even be aware as to what is going to happen next, right? In addition, several drug substances may also cause irritation if the powder is aerolized and inhaled and it comes in contact with your eyes and skin. So when you're finished, you might find yourself itching and you're wondering, why am I itching like this? All right. So let's all just bear these in mind. Drug irritation, we would have basically spoken to this already about the irritant actions. And of course, it's not just to the outer areas now, but for the patient who has to be ingesting it, right? You can also have stomach irritation, all right? Or anywhere along the GI tract. Unacceptable taste, right? We would have basically alluded to this before. The dosage form effects. Now, here I'm just going to, I'm seeing where Georgia Sanchez is saying that she's not hearing. I'm not too sure if this is happening with other persons. So if it is not Georgia, you probably need to just check to see if it's something with your particular device. Dosage form effects, extended release preparations, right? They are actually formulated to release the drug over an extended period of time. So let's say 12 to 24 hours, right? And we are so happy for these preparations because it really does help with adherence, because persons just have to literally take these medications once or twice daily, right? And so we're happy for them. Nonetheless, because we are aware of this now, we have to know that these are not preparations that you're going to be fooling around in terms of crushing them or opening up the capsules or splitting, right? Because we are going to be interfering now with whatever matrix, right, the drug is in that is allowing for the release, right? So although to us it just looks like another medication, you know, we'd have to start looking at it as a system, right? And within that system, you know, there is some form of scientific measure that has been used now, whether it's by something osmotic or so on, to cause the drug to be released. And once we interfere with the drug, we are interfering with that system. All right, just to point out to you some of the things you can look for to know these drugs, right? These controlled release medications or sustained release medications. And here are some of the things that you will see, right? Some of them you may never have seen before, myself too, but the fact is, it's good to look at all of them because then you become a little familiar. So when you see a drug and you see its name and then you see after the name XT or ER or so on, it is indicative that this particular drug is possibly one of those that you need to be careful about interfering with the drug itself. All right, we would have spoken about enteric coatings, all right, and how these help to not only mask unpleasant taste or smell, but also in protecting the GI tract, right? And so we don't want to be interfering with those coatings. And that's basically what is being spoken about here. All right. Marlene is not seeing the slide. Not sure what's happening with you, Marlene. All right. Other types of dosage forms. You have sublingual buccal tablets. I find for the most part, persons are very much aware that there is really no need to be interfering with these forms, even if you find that some of them are larger sizes, right? Definitely you don't want to. You want to ensure that these are kept in the mouth until they're dissolved so that they can get into the circulation for, in most cases, more rapidly. All right, so you have the absorption across the mucosal membrane, leading to a rapid rise in the drug concentration in the blood. And the one that most of us are very acquainted with would be like your GTN, right? So you don't want definitely to be interfering with those medications. All right. And so these other slides continue to speak to the reasons for not pushing your extended release preparations. All right. And I just want to just highlight this little area that speaks to crushing sustained release isosorbide mononitrate tablets and administration through your NG tube, right? In a 78-year-old patient produced recurring chest pain and nausea, right? And the reason for this no was that it was a long-acting preparation, right? And the resolution would have been, okay, the patient has in a tube, let's use a short-acting version instead and dose it appropriately. All right, so we're basically now just down to the very last of what we are discussing, all right? Recommendations regarding altering medications. As I go into that, I just want to remind us of the rights of medication administration, right? And these rights are really put in place to help us to minimize the possibilities of making errors and to optimize the safe delivery of the drug to our clients. And we know that they have moved from 5 to 10 and all sorts of things, but they're the 5 traditional ones. Could I see you putting in the chat the 5 rights of medication administration? I know some persons not so quick on the typing, you know. So if you can even just put in one of those rights, it would be appreciated. I have to make sure you're with me. Okay, right patient. Thank you, Karine. You're off to a good start. Definitely. Right patient, right time. Thank you, Miss Cameron. Right dose, yes. Right drug. Yes, all right. Thank you very, 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 very much. Okay, so I'm just reminding us of these because as we even look at alterations, because I know you'll go more into that, but as you look at alterations, we want to say that we want to know that drug, the product itself, the right drug, that we don't do anything in manipulating that right drug to the point that it becomes a part of a safety issue for a patient. So yes, right patient, right drug, right route, right time, right dose, right? And remember, the altering of a drug can affect the right dose. Not true, right? The right dose being given, right? And so we have to really be careful. All right, so just looking at some things that can be done. Now, this is very general, certainly not exhaustive. So it is not saying that, okay, because something is mentioned here, oh, this is how we're going to do everything. And I know that we would all understand that, but I just have to make sure I put it out there, right? So solid dosage forms, okay? They must be manipulated before, let's say you're using an NG tube, right? So sometimes you have a powder for suspension, or basically a slurry is made, right? For your tablets, most simple compressed tablets, all right? Those that are immediate release tablets may be crushed, right? So crushed to a fine powder using a mortar and pestle and mixed with water and so on. So that's the case for most. But as I said, because we have so many variations, right? We have to be careful. And so it always makes sense to make sure that you are aware as to whether or not this tablet is suitable for crushing. As for capsules, you have your hard gelatin capsules with powdered drugs. Yes, at times we can open, all right, and then dilute the contents with about 10 to 15 mils of water to form a slurry before administration. Then you have your liquid filled soft gelatin capsules, and that would be like an example of the valproic acid, depending on the brand that you would be looking at, all right? For this now, there is the ability to pierce one end of the capsule with a needle, extract the contents into a syringe, or squeeze out the contents and mix with water. All right, so that is one way that it can be done. Also, there's the whole thing of dissolving the entire soft gelatin capsule in a container of warm water and administer all the contents, right? But this one can, I would not so much go with this one if the other could be best done, because you have to be careful with occlusion, all right, especially if it's going down the NG tube. Then you have your extend release capsule with beads or pellets, right? So you have some of these now that we're not talking now about the tablets and you have to go crush it, but it actually comes as a capsules, and in the capsule itself, every pellet has its own design. Now, in these situations or in these circumstances, the capsule can be opened and emptied into the feeding tube, all right? So the idea is to not crush the contents, all right? And then there's also the ability to make a slurry. So in this instance now, you're talking about, it's basically just suspending the beads in water, you know, trying to mix them out, all right? Okay, and so these are the intricacies about using these medications with a tube, all right? Then you also have to remember that in trying to give medications via NG tubing, there needs sometimes to stop the enteral feed 1 to 2 hours before and after the administration of medications like your phenytoin, all right? Because what you can have is that you're not going to end up with the patient getting the correct dosing if there's an interaction between the phenytoin and the actual feed itself, okay? Whole lot of monitoring, whole lot of monitoring, all right? Dabigatran, interestingly, I heard someone mention this, so I hope that person is listening up, right? Now, this particular capsule, all right, it is definitely a no-no to open this particular capsule and to say that you're going to be placing it down a tube, or that you're going to be trying to get it to a patient who is not able to swallow it whole, right? So that's rose pinnock, right? All right. It is a no-no, because what you find is that the opening of the capsule results in a bioavailability, meaning that how much now becomes available to the patient. It's an increase of 75%. So you know what you're looking at, right? An increase in the possibility of that patient hemorrhaging, right? And so really for these medications, what is the recommendation is that you switch to an alternative. Whether it's warfarin, yes, we know warfarin comes with more monitoring and all of that, and you know, care with what the patient ingests and so on. But warfarin, and then there are other oral anticoagulant medications like afixaban, rivaroxaban. Those are persons who are in the public health system might say, but we don't have those. But you know, we have to really put the patient's health first and foremost. And as I said, we ourselves will grieve if we find that we are finding ourselves in a situation where the altering of the medication caused any harm to our patients. Okay. So as we wind down, the importance of education, communication among nurses, physicians, pharmacists, all of us have to work together, right? In ensuring that our medications are delivered safely to our clients. We have to keep the conversation going and even increase it, right? Medication safety is paramount. Remember that you should feel free to consult with your pharmacy personnel, all right? If crushing of tablets or the opening of capsules is to be considered, useful information on whether this form of manipulation is appropriate for a drug product can be found in literature. One such is Handbook of Drug Administration via enteral feeding tubes. That's a very good book to use. And of course, I'm sure just looking through various sites, all you want to know is that it's a credible site can help. So basically, our objectives were to review the dosage forms, to discuss reasons for and methods of altering dosage forms, to explore disadvantages of altering these medications, and to discuss some recommendations, right? I know you are pressed for time, so I'm just showing you quickly my references and saying to you, thank you so much for having me. I really appreciate this opportunity to present to you. God bless you. Okay, I'm not too sure if someone is speaking now because I'm not hearing. I think our moderator is speaking.
Hello, good morning, everyone. Are you hearing me? Are you hearing me, Dr. Shaw?
Hearing you now, hearing you now.
Beautiful. So I want to say thank you so much. Excellent, excellent presentation. I know some of us may have been guilty of altering some of those medications in terms of cutting to ensure that our patients get. And today we are reminded again that it is not correct to cut these medications because we may give either too little or too much of the dosage. And so I'm hoping that going forward, we will desist from doing that practice. So thank you so much again, Dr. Shaw. Is there any question, any other question? I know it was a very interactive presentation. So many persons were able to ask questions and participate throughout the presentation. And so I doubt there's any more questions to be asked. So thank you so much again. Do enjoy the rest of your day. And we are going to move right into the next presentation. And this too have to do with medication as well. And so we are going to be welcoming our second presentation, Mrs. Naomi Foster, and she too is a pharmacist from the Managua Regional Hospital. She is going to be speaking on correct administration of medication. So we're all up into medication this morning. So we are going to allow our technical person to allow Mrs. Naomi Foster to present to us on correct administration of medication. Then this presentation should be a shorter version of the one before.
Good morning. Hello. No, yeah.
Morning, we're hearing you, Naomi.
Thank you. No.
Yes, Mrs.
Thank
Foster,
you.
we're here. Yes.
Thank you. There it is. All right.
And I trust that everyone should be seeing the screen. Can you just let me know? Okay, you have to unmute your microphone, Mrs. Foster. All right, great. Yes.
I am hearing you. Could you just give me 1 second? I have a little bit of a technical issue.
Okay, no problem. All right.
Can be added to the register, please. Okay, good morning again. Sorry for the delay. So Mrs. Foster is having some technical challenges, and we're going to move right into our next patient from the main hospital. He will be talking about nephrotic syndrome in children. So he'll just be enlightening us on the treatment, on the disease of nephrotic syndrome in children. So, Dr. Price, welcome. Hello, Dr. Price. Curtis Price. You can unmute.
Hello, good morning again. I'm sorry. Not Dr. Price.
All right. Are you okay, Mrs. Foster? Are you able to go ahead? We had just introduced Dr. Price, but if you're okay, we you.
Yes,
She's
I am
ready.
okay, and we can go ahead. I was saying to myself that Dr. Thor presentation, I need not even be here. But
all right, so we're going to. So we ask again, Price, to just give us that half an hour, and we'll allow Mrs. Foster to go ahead.
Okay. So thank you for the invitation, and as was introduced, my name is Naomi Foster. I am a pharmacist at NTU, correct administration of medication. As I was saying earlier as well, Dr. Shaw said everything. So I don't have to say a word. But let us proceed. Next slide, please. Some of the tenets of correct could you slide down, please? Of administering medication is the delivery of the active ingredients to the site of action where it can have an effect. Now, if you also in any way this
Mrs. Foster, I'm not sure if you're hearing me, but reception is in and out. I'm not sure if it's, well, if it's from your side or it's my side, internet is unstable, but you're in and out. I'm not hearing you though. All right, participants on the platform, could somebody say something just to see if you all are hearing? Because I'm not hearing Mrs. Foster.
I am not able to hear her well either. So I will try to get onto her for you. This is Shaw.
Okay.
Okay.
Thank you very much, Dr. Shaw.
Okay.
All right.
Hello.
Yes, Mrs. Foster. I'm hearing you now, but you're in and out. It seems as if your internet is unstable.
I don't. Oh, I don't know. I've been speaking for a while and then I realized everything is quiet. Wondering if anyone is hearing me. Please just send a pop up so I know. I cannot see the presentation. Is the presentation still being shown?
Yes, yes. So yes, I'm at the introductory. That's the second slide.
Okay, thank you. So let me continue from there. Okay.
So just to confirm, you're not seeing the presentation.
I am seeing it now. I wasn't seeing it earlier.
Okay, great. So all right.
right.
So I'm at slide 2. All right, great.
Okay. All right. So what I was saying as of slide 2, I was saying that it is important to remind ourselves of the goal of administering medication. And the goal is always to ensure that the medication we administer get to the site of action so that it can elicit the effect that it's intended for. There are various factors that affect this, and these include the dosage form, the dose, the patient, the route, the time it's administered. And these are the main factors. There are others, but these are the main factors. No. In order to maximize the delivery of the drug, it is important that all of our citizens. So next slide, please. No, in considering these factors, we consider it under the tenets of what we call the 5 rights of the patient, which Dr. Shaw did speak of. The right patient, the right drug, the right dose, the right route, and the right time. Some of which Dr. Shaw spoke about earlier, and I touched on earlier as well. Next slide, please. As a quick overview of dosage forms, we will remember that medication comes as various dosage forms, and I won't go into those much because Dr. Shaw did speak about them, but just quickly, from the perspective of a pharmaceuticist, that which I am, you consider how drugs present themselves, because the whole purpose of medications is to ensure that the acceptability of the patient and the delivery of the drug to the site of action. So these drugs are formulated in different forms. So you have the solid dosage forms, which we talk about as tablets, capsules, suppositories, pessaries. You have the semi-solids, such as creams and gels and pastes and ointments. And you have the liquid ones, such as solutions, suspensions, emulsions, etc. You might have nano-emulsions and so on. No, various dosage forms might be chosen for the various reasons. And I think Dr. Shaw said something about that this morning. No, the reason comes right back to who you're or who the recipient of the medication is. Also consider what you are treating. So if it is a situation where you are treating something that, like, a person has a very treating with an oral dose option more when it goes through the track. You might need a solution or next, please. So we'll just run through these very quickly because they were covered a bit early. You find yourself coming across are tablets or capsules or suppositories. Now, from the perspective of pharmacy, tablet is not the device that you use to find your games and apps. It is a solid dosage form that contains an active ingredient pressed together to form one unit. And we stress one unit because when you crush it, it is no longer one unit. And so delivery to the site of action might be affected. It comes as different shapes and sizes and colors. And sometimes you find clients will say, oh Lord, it's too big, or I can't swallow it. Could you go to the next slide, please? And because they can't swallow it, then we crush them, etc. But not all tablets are to be cut or split, as Dr. Shaw spoke of this morning. Solid dosage forms in the form of tablets are the most popular because they are very convenient. You can carry them everywhere. They are very discreet. Nobody needs to know that you're taking medications, etc. But not all tablets are created equal. Some are coated with a sugar coat to make them more palatable or to make them more aesthetically pleasing. Some are modified release, which means that more than one dose is in that one tablet. Now, when you crush or cut that tablet, you have released quite a number of medication at once, rather than over a period of hours or minutes or a longer period of time than that was intended. So when that happens, you run the risk of causing harm to the patient. So we always say modified release dosage system, and these are not just tablets, but we're talking about tablets right now, can cause a lot of harm if not administered properly. The suppositories and pessaries. Suppositories are usually intended for administering to body cavities, like the vagina. For pessaries usually in the suppositories are usually intended for the rectum, or in some few cases you might have even trouches that you put in your nose or your ears and so on. But usually for the rectum, and the pessary is usually intended for the vagina. They must be stored properly because they are intended to melt at body temperature. And sometimes, on the wards, it can get pretty warm. If you put it in a place where it is not stored properly, they'll melt before they get to the patient's use. Could you change to the next slide for me? No, there are two types of capsules that are generally found. There are the soft gel capsules and the hard gel capsules. Most times what you'll find are on our markets are the hard gel capsules. Those hard gel capsules are like your metronidazole. You'll find other things like your doxycycline and so on. And the soft gel ones usually contain a liquid like your valproic acid, your cod liver oil, your calcitriol. They are generally intended to be swallowed whole. A few of them you might find where the persons might be told you can open it into some food or some drink or so, but you must take the entire content of the medication. If these are taken, are not stored properly, or they are taken with liquids that are too warm or so, you can melt the shell. When the shell is melted, then the medication will be released into the mouth or in the stomach when it was intended to be dissolved in the GI, in the intestines. And if that takes place, then you would have interrupted the dosage form and might cause harm to the patient or destruction of the medication itself. Could you go to the next slide, please? Now, when administering a solid dosage form, it is important that you administer with sufficient fluid. If you do not have enough fluid for a capsule, for example, and it gets wet, because most of these capsules are made of a gelatin outer coat. You put them, water touches them, they get moist, they get lodged in the throat, and that can cause harm to the patient. Tablets likewise can get lodged in the throat, so it's important that sufficient fluids be given to ensure that the tablet or capsule is delivered to the GI tract. Don't ever cut or crush modified release dosage forms, because those can disrupt the whole dosage form itself and cause more release of more medication than was intended and cause harm again. Administering medications like capsules with hot liquids like tea can cause, as I said, the melting of the outer coat, which we don't want. There are buccal tablets, as Dr. Shaw mentioned, I think, and sublingual tablets. It is intended for these to be dissolved in the mouth. Now, most of these tablets, they are given in this way because the solution in the mouth ensures quick absorption. But you also have some of them, when you administer them, you swallow them, they are deactivated by the acidic condition of the gastrointestinal tract. And that could render the medication unusable or of no use. So the patient's taking medication that is of no use, and they're not getting a therapeutic response as a result. If you are administering a dispersible tablet, some forms of aspirin come as a dispersible. it is important that it is dissolved in water before it's taken, because some of them have an acidic base. So if it's not dissolved in water, it foams up in the patient's mouth, and then what happens, sometimes the patient spits them out. And it's always important that tablets and capsules and all solid dosage forms are kept cool, dry, and away from moisture or things that could interrupt the dosage form itself. Could you go to the next slide, please? Now, the liquid dosage form is chosen because it is often easier and more acceptable to children and persons who are not able to take tablets. And I give you a snippet of some things that happen in our practice. I remember there was a lady who I came across once. She's adult, but she just cannot swallow a tablet. She has a psychological barrier, she says. So you gave her, she was prescribed a capsule, and here she is trying her very best to swallow the tablet, and to say each time she swallow it, it just a capsule, sorry, it just comes back up. So in a situation like that, we can recommend a liquid dosage form such as a solution. The issue a lot of times though with solutions is that sometimes they are not always tasty, because the drug product in solution, the patient will get all the taste on the mouth, and which can cause problems in administration as well. As I mentioned before, liquid dosage forms are usually very useful in children and elderly persons and persons who may have difficulty swallowing solid dosage forms. They do offer the advantage of being ease of absorption from the gastrointestinal tract. So when you give a liquid dosage form, what will happen is that the patient will get that dosage form quicker into the bloodstream than if a tablet is given, because the tablet has to go break down in the stomach, then it has to be absorbed, etc. When it's already in liquid form, it's only barrier that's there is absorption into the bloodstream. Liquid dosage forms can come in varying forms. You can have them administered enterally or parenterally. So you'll have a normal saline that you give by IV injection, whereas that the DPH or paracetamol, a lot of times are given by a liquid dosage form. Next slide, please. Now, you also have suspensions such as the antacids, and your suspensions are usually those that have undissolved matter in them. So you have like milk of magnesia, other antacids where it's just not solubilized, but you can have it taking place in a liquid dosage form to deliver the drug, and it will not lose potency because it has been so formulated that when you shake that medication, you pour it, a dose is in that 1 teaspoon or 2 teaspoons or so on. You have emulsions, which we don't come across a lot in the pharmacy practice because people don't really like oily substances. However, one that is of note is the fat emulsion, the intralipid that we see often. That is an emulsion. It's a micro emulsion used for IV administration. Usually you have an oil dispersed in a liquid or aqueous phase. Inherent in emulsions is that they're unstable. So they must be protected so that they don't cream or crack. Next slide, please. All right, so when administering liquid dosage forms, be aware of what dosage form it is. If it's a solution, the administration might be a little bit different from a suspension. For example, if you're giving a solution orally, there is no need to shake it because it is only one phase. All the medication is in one phase. It's already dissolved. However, if you are giving a suspension or an emulsion, it is possible that the active ingredient or some of the ingredients can quote unquote settle out. And if they settle out, you need to gently shake to redisperse. And I say gently shake because these both suspensions and emulsion, but more so emulsions, are thermodynamically unstable. So if you shake them too much, what can happen over time is that you interrupt the interface between the solid particles and the liquid particles, or the oil and the water. And what takes place over time, you have creaming, cracking, or you have precipitation. In essence, you have instability of the dosage form. It is always a good idea to ensure that you have an accurate measure. And in pharmacy, we always say that you dispense with a calibrated measure. Don't just say to the person, use a teaspoon at home. Take a teaspoon, because all teaspoons are not created equal. You know, your teaspoon might be different from mine, and person's interpretation of a teaspoon might be different. Some persons, the teaspoon is the spoon that they use to mix their tea with, which could be a tablespoon or a dessert spoon. In essence, use a graduated measure. And a lot of dosage forms these days do come with graduated measures. When a solution is being given IV or IM, it is always important that you ensure that you examine to make sure that that solution is free of debris. There are some suspensions and some emulsions that are also given parenterally. And it is important as well to ensure that these medications are actually in a situation that they are stable, right? So if there's any doubt at all, I always say, when you're in doubt, you always check. Now, next slide, please. There are some factors that I think I touched on before, but I'll just say again here. There are drug factors that affect how you administer medication. As we had said before, is it immediate release? Is it modified release? And there are injectables, there are tablets, there are suspensions, emulsions that can be modified release. For example, in most of the depot injections, they are modified release. So they are supposed to be given over a long period of time. If these are not injected in the correct place, what will happen is that you can cause harm. So for example, if you have a depot injection and it is accidentally injected IV, that is going to kill the patient right away. If you are administering something that should be given IM and you give it IV, you can cause great harm, because they are not, sometimes the diluents are different and they are not to be interchangeable, and they can cause harm. So you just be sure to know what it is that you're administering. Read the package clearly, correctly before administration. Make sure if it says for IV use or for IM use, etc. If the agent is bulky as well, the drug itself is bulky, it might not be the best agent to be given under the skin or as an IM medication. In addition, there are some medications that if given IM for too long a period of time, like the diclofenac, it can cause damage to the muscles. So it is important to have those drug factors known. And pharmacy is one of those places that we're always happy to give information. So if you're unsure, give us a ring. We will check for you if it is not stated in your literature. Now, could you go to the next slide, patient-specific factors? The patients are, I suppose, one of the most important factors that are to be considered in the administration of drugs, because they're the ones taking it, right? I mean, we can make the drugs all we want and we can be wonderful professionals all we want. If the patient does not take the medication, no benefit will be derived from the patient. So we need to consider who we're administering the medication to. Is it a child? Is it an adult? Children might have difficulty swallowing a solid dosage form. Children, adults might not like injections. I've come across a few adults that like, oh, miss, I can't take no injection. Yes, and things like that. So you have to consider who you're giving the medication to. Are these people taking any other medication that could potentially interact? For example, you're giving a fluoroquinolone such as ciprofloxacin orally, and then you're asked to give an antacid. That you lose probably about 40 to 50% of norfloxacin if given with an antacid. If you administer methotrexate with folic acid on the same day, you will get no folic acid and you'll get no methotrexate because they're competitive inhibitors. No, so it is important to know, to have a good history of the patient. What are you taking? Do you have any issues swallowing medication? Do you have any fears or concerns regarding injections, etc.? You need to know whether the person in this history will tell you whether the person can swallow things. You need to know, you would know your patient's state of health because they might be lying on a bed. Are they alert and coherent, and can they understand that, yes, you need to swallow this thing? or so, or they disoriented, are they unresponsive, are they comatose? In which case, you might say, okay, do we give them enterally or parenterally? There are some medications, and as I reference again Dr. Shaw's presentation, that it is not a good idea to crush. So an IV or an IM option might be preferred. Some of these medications, they block the NG tubes. Some of them, you crush them and you dump a whole 2 or 3 doses in one sitting on a patient. The patient's pressure drops too low, the patient dies. Now, you also need to find out if the patient is okay with taking the medication. Some patients, as we said before, will not take a tablet. So you might need to give a liquid, but of course that liquid might not taste so well. So you also need to prepare that patient for that. Next slide, please. I touched on the route of administration before, but just to speak a little bit more about it, parenteral therapies must be sterile. It's not an option because remember, the patient has no defense against this medication once it goes into the bloodstream. So if it's not sterile, or if you are unsure whether it is sterile, do not use it, because you might put the patient at greater harm. And as we know, the parenteral routes are there. It requires trained person, which you are, to administer. So therefore, because it requires trained person, you also have to ensure that you do your due diligence to ensure that the medication that is being given is what is ordered. So you double check, because these days sometimes we get some medications, they are lookalikes, that they are very, very close, the print is fine, and so on. And if you are in doubt, make sure that you err on the side of caution. The parenteral route is of course preferred for quick onset. However, once you administer it, taking it back is kind of difficult, because it's already in the bloodstream on the way to the site of action, and then you can cause harm. So double check and make sure. And so when you are going to administer any IV, IM, IT medication, always check to make sure there's no debris in it. There's no precipitate. It's not colored. It is not if it's different from what you're used to, double check. All right. Check the expiry date of these medications. Make sure that they are supposed to be good. And even sometimes the expiry date, storage can compromise them. So just double check to make sure they are what you are accustomed to. And if you're unsure, seek advice. When administering things, especially IV ingredients, when you're piggybacking them, you have to make sure they're compatible. So like something like a diazepam and normal saline should not be administered together, because you could have a precipitation taking place within the liquid. You have other drugs, and handbook of IV preparations or co-administration is very useful. Some pages of it you can get online. Next slide, please. When administering things topically, I know sometimes persons have ulcers that need to be taken care of, or might have a bed sore or a rash. Topical administration might be preferred in that situation, because it's a local effect sometimes, and you need to apply it there where the product will be most effective without causing a systemic response if that is not required. The issue though with topical administration in most cases is that the absorption is erratic. So we usually try to limit topical absorption to things that we need local therapy for. And you know the ones that you come across: the creams, the ointments, the pastes, the gels. These are different formulations and should be applied for different purposes. A cream usually is preferred for areas that do not need great degree of moisture, of emolliency. It has a higher concentration of water, so therefore you might need apply it to an area that needs moisture. The pastes are thicker and might be preferred for an area that is oozing and need something to help with the absorption of water. Gels can generally dry the area. So if the area is already dry, a gel might not be the best option. And in general, when you are applying any of these agents, make sure the area is clean and dry. and you apply some of them, like the paste, you might need a spatula to help with the application because they're very viscous and they're hard to put on and hard to take off. And sometimes in removing, you might need to clean with extra solvent to ensure that they are removed completely. Transdermal delivery systems are also available. What we have in most of the pharmacies as transdermal delivery is the fentanyl patch. These are extended release preparations. In terms of the fentanyl patch, once you put on a patch, it should not be removed and reapplied, because the patch, once you put it on, there is a coat that is on it that fuses with the skin, and once that coat is disturbed, it cannot be reapplied to cause the drug to be released at the controlled rate it was intended to be done. You should never cut them. You should never break the device. It should be applied as it is removed from the packet. The area of application should be rotated because it can cause irritation if the same site is used over and over. Next slide, please. And we're coming to the end. All right. Okay, so I know for most of the times you might not have a lot of patients who you have to administer ear drops to or nose sprays, but it's important, as we all learn in school, that you start with clean hands. With every dosage form, you clean the area of the organ, so either the eye or the ear. If it's the eyes, you tilt your head backwards, put the drop in, wait a minute. The eye can only hold one drop at a time. So if you have both eyes, you can put a drop in each eye, wait a minute. Some books will even say go up to 5 minutes before you apply the next drop. And try as best as possible to prevent the tip from touching the eyes. If the tips touch the eye, as soon as you possibly can, you clean that area. You clean the tip. Next slide, please. For the ears, it's as said before, you clean the area, tilt the head in order to expose the ear, and you place the drops in and you allow the ear to remain in the same position for 2 to 3 minutes so the drop does not run back out. And before you apply to the next ear, if that is recommended. For the nose, we always say blow the nose first to remove any debris. Then you insert the nozzle into the nostril and you spray. And you can repeat that. Inhale after spraying in each nostril. Next slide, please. Now, when we are giving medications, usually most times when you'll see the pharmacist will say, give every 8 hours, give every 6 hours, give 3 times a day. It is always a good idea to use a 24-hour clock. Why we use a 24-hour clock? Because medications have a period of time that they work. And just as a reminder, the half-life of the medication is the time that it takes for 50% of the medication to be depleted. No, if you give the medication outside of the time when you have a concentration in the body that is required to elicit its effect, that is the minimum effective concentration, what will happen is that the efficacy of the medication will start falling. And then it's like you're undoing the effort, the work that you have done in administering the first dose. In the same breath, if you're not careful and you administer medication too early, you can end up giving too much, and too much is available in the body, and you end up with a toxic dose. This is a dose that is more than the patient requires to elicit its effect, and that can cause that danger. So it is always important to ensure that the time is adhered to ensure the correct amount of medication is in the body at any time. The ideal time will guarantee that not too much and not too little medication is in the body to elicit its effect. We do not want to cause harm. Next slide, please. And this is one that persons always get a little, edgy about. Do I need to take my medication with food? Truly, most medications are preferred to be taken on an empty stomach. Why? Because if you take medications on an empty stomach, what happens is that the medication is absorbed faster and more thoroughly. So therefore, generally speaking, medication should be taken on an empty stomach. There are some medications that food actually reduce its absorption. So therefore, if you take it with food, you will lose some up to 40 to 50% of the medication, the effect of which you might not get at all. So a medication like norfloxacin, the fluoroquinolones generally, ciprofloxacin, captopril, if you take those with food, you're going to lose a big chunk of the medication. So we usually say take an hour before you eat. An hour before you eat or on an empty stomach or 2 hours after you've eaten is preferred for medications that need to be taken, must be taken, I should say, on an empty stomach. Medications that do better if taken after food include griseofulvin. Griseofulvin is absorbed better in a situation of fats. So if you have more fats in the stomach, you'll get a greater proportion of the griseofulvin being absorbed. Griseofulvin has very poor absorption. About 30% of the medication will reach the site of action when taken without food. But when you take it with fatty meals, it increases to about 60 to 80%. So it's important to be taken right after the meal or while eating. Food also might impact the effect of the drug on the GI system, such as the NSAIDs. Whereas taking the NSAIDs with food does not eliminate the GI upset, it does reduce the effect of the NSAIDs on the stomach. Unfortunately, however, it might still require that other medications are given to prevent ulceration from these agents. So the long and short of taking medication with or before food is that know the nature of the medication. And if it says before food, that should be adhered to. And if it's after food, that should also be adhered to. And I finished the next slide, and this is where I will stop. No administration of medication is complete if the medication is not stored properly. If a medication is to be refrigerated and it's kept on the counter, what will take place is that the medication will spoil. If the medication is spoiled, so a medication such as Baractant or Recorman or Mercera, which are biologics and they are very but they are not stored properly, you cannot guarantee that the dose that you're given to the patient is accurate. And if you can't guarantee that the dose is accurate, then you don't know if the patient is getting any medication at all, and it is doing any good to the patient, or if it's doing harm to the patient. I thank you for your attention. Sorry for the many glitches, and I hope you learned at least one thing from all this presentation. Alrighty? And there is where I end. Sorry for all the background noise as well.
Thank you so much, Mrs. Foster. Excellent presentation. There is never too much knowledge, and we do understand the glitches. We too are having some here as well, the challenges of technology. And so we thank you again for your presentation, ma'am. And I'm sure we will put the reminders that you have given us, we'll put them to good use. Thank you, and do enjoy the rest of the seminar. God bless you. And so we will move right into the next presentation. Dr. Price has been waiting for a little while, and so we welcome you, Dr. Price. Good morning, Dr. Price.
Morning, good morning.
Thank you. Good morning, sir. Thank you so much, and we do apologize for the delay, but we will just move right into your presentation. We're very eager to hear about nephrotic syndrome in children. All right, so we're seeing you up screen, on the screen. Thank you. Go right ahead.
All right, good morning, everyone.
Morning again, sir.
All right. I would like to thank the organizers for inviting me to speak on this very important topic.
You are most welcome, sir.
I want to commend you for a very successful program. I see over 200 persons joining. And
yes, that's very, very, very exciting. You know, we're
Yeah.
really happy to have our participants. We really want to say thank you so much to our participants, and they have been very good from this morning. They have been patient with us, and we really appreciate them. Thank you so much, participants.
Yes, man. Well done. All right.
Yeah.
And all protocols observed. I will be presenting on the topic nephrotic syndrome, with particular attention being paid to nephrotic syndrome in children. All right, so we'd like to start out by looking at some definitions, and that definition is really not spelled properly at all. Nephrotic syndrome is not a disease entity in itself, but really what it is a group of disorders, and they are characterized by an increased permeability of what we call the kidney filtration barrier. All right, so we'll look at that in a little more detail, but basically within the kidney, there is a barrier that we call the filtration barrier. When that barrier is affected, what it results in is massive protein urea and edema. And I think I'm speaking to a medical group. So, right, is there non-medical persons in the group?
Okay, I'll speak to you.
Repeat that.
Okay, yes, there may be non-medical persons, but the majority of persons in the group are affiliated with health care.
Okay, good. All right, so when we say edema, we're basically talking about just swelling of the body, all right? The most common etiology for nephrotic syndrome in children is a disease entity that we call minimal change disease. So whenever we speak about nephrotic syndrome and children, the entity that we usually is the most common presentation is what we call minimal change disease. And this is a picture of the functional unit of the kidney. So basically, if we break down the kidney into its microscopic unit, and then one functional unit of the kidney will look like this, where you have that section where that red section, it's a collection of modified blood vessels, right? And that is where filtration of the blood occurs. So the blood passes through that area that is called the glomerulus. It is filtered, and then it passes down through those yellow tubes where substances are reabsorbed, and then eventually in the collecting duct, the urine is produced and is filtrated. So the area that we'll be focusing on for nephrotic syndrome is the glomerulus, right? All right, so this is a more detailed look on the glomerulus. The red part is the blood vessel, called the glomerular tuft. The blood passes through there. It is filtered, all right, and the filtrate, that is a substance that comes off the blood, passes through that section called the Bowman's capsule, that's a yellow section, and then it passes down towards being excreted in the urine, most of it. If we look at a little more detail, this is the microscopic picture. When you look under a microscope, I want you to pay attention to 3 layers. The innermost layer is the endothelial layer. That is where the blood vessels are, right? That red section. And as we move through, there is what we call a basement membrane. And those 3 little elephants at the top, it's really epithelial cells. So the blood or the filtrate, I'm not sure if you're seeing my arrow, it's moving from this section, moving across the endothelial cells, then across the basement membrane, then it has to move across the podocytes, which are really epithelial cells, to be excreted. Hello? All right, sorry about that, to be excreted, all right? So that's what we call the trilaminar filtration barrier. So the epithelial cells have to be intact as the blood is filtered across the strainer. The basement membrane has to be intact and the epithelial cells has to be intact. And all of those three together prevent substances that you don't need to be filtered from passing across here into the urine. All right, so basically we're looking at what really happens in nephrotic syndrome. With minimal change disease, which is what we'll be focusing on, they're not quite sure, you know, exactly the micro details as to what causes it, but there are some suggestions. So it's thought to be related to a disordered or dysfunctional T cell function. So there are some cells in the body, white cells, that are involved in the immune response. They're called T lymphocytes. If they're dysfunctional, then that is what is thought to produce these cytokines, which are basically products produced by the lymphocytes, and they cause the filtration barrier to become permeable or leaky, right? So they refer to them as permeability factors that are secreted by these T lymphocytes that affect the filtration barrier, those three layers, and result in the leakiness of the glomerulus, the proteins. The permeability factor injures the epithelial cells, those are the little elephant cells on the top, in such a way that they alter the production of certain proteins that are called polyions. And when those are affected, it causes molecules such as albumin to leak out of the kidney. All right, so remember we talk about the trilaminar barrier. Tri means three, those three layers of protection that really prevents, right? And two things happen. The proteins that are affected in nephrotic syndrome, in minimal change disease, they have charges on them. And the charge that they have on them are negatively charged. The proteins in the body, the main one being albumin, when it approaches the negative charge, because it's -2, the two negative repel each other. So there are two things that prevents albumin from leaking out of the kidney. And these are, you know, the negative charge of the membrane and the pores. So the pores are also affected, meaning holes form inside the trilaminar membrane and hence cause leakage of proteins. There's another entity called FSGS. You might have heard of it. It's not as common as minimal change disease, but you know, probably second. We have a couple of children at the hospital and in our practice with both minimal change disease, and you have a couple of them with FSGS. FSGS means focal segmental glomerulosclerosis. So basically there is inflammation of that little capsule that we spoke about a while ago. All right, there are other factors. So you might have known, or you might have heard about people with lupus, otherwise called SLE. Basically, it's an autoimmune disease where the body produces antibodies that attacks itself. And one of the organs that are affected with SLE or lupus is the kidney. All right, so the glomerulus becomes inflamed and leaky. Other entities include what we call membranoproliferative, some big names, but I've mentioned them because you're going to hear them around. You have what is called post-streptococcal infection, and you might be associated with this one with respect to rheumatic fever. So the same sore throat that causes rheumatic fever is the same one that can also affect the kidney and can cause a nephrotic syndrome. Usually is, a nephritic syndrome it causes, but it can cause the proteins to leak from the kidney as well. And finally, this one is rarer than the others. You have situation where babies are born with nephrotic syndrome. And you might wonder what is going on to cause a baby to develop nephrotic syndrome. So we have had some babies who develop nephrotic syndrome, and it's related to a congenital mutation in the genes, which cause their epithelial cells not to develop certain proteins that is necessary to prevent albumin and other proteins from leaking out of the cells. All right, so we call these congenital nephrotic syndrome. So if you meet a baby who is less than 1 year and who presents with nephrotic syndrome, then it's likely to be related to something that is born with a mutation that affects the structure of the glomerulus. Don't forget there are other disease entities such as sickle cell disease that can cause nephrotic syndrome. So the sickle cell disease can affect the kidneys. HIV is notorious for affecting the kidney as well. Hepatitis B, and we're giving hepatitis B to newborn babies in Jamaica now. And one of the reasons is that hepatitis infection can affect the kidney and cause kidney disease. Hepatitis C as well. Some patients with leukemia, they can develop nephrotic syndrome as well. And NSAIDs such as your Cataflam, Brufen, and or medications like those, you might be aware that it can affect the kidney, damage the kidney, cause renal injury, but it can also cause a nephrotic syndrome as well. One of the pharmacists mentioned greasy of fulvin, and it sounds greasy. As she said before, you should take this with fatty food because it enhances the absorption. Greasy of fulvin can cause nephrotic syndrome. Actually, I have a patient, real life, who I gave greasy of fulvin for tinea capitis, that is a fungus of the scalp. And within 2 weeks of starting the greasy of fulvin, he developed overt nephrotic syndrome. We had to take him off the medication and start him on his treatment, which we'll discuss later. And he eventually resolved and it never recurred. So greasy of fulvin and some other medications are, notorious for causing nephrotic syndrome. If we were to classify nephrotic syndrome, it can be classified into different ways. The primary ones are where there is no systemic disease. So the patient doesn't have lupus, or any disease condition like that. It can be secondary, where there is a systemic disease present, such as HIV, lupus, and stuff like that. And of course, it can be congenital. All right, and congenital disease can be primary or secondary, meaning you're born with a mutation, or it can be secondary to an infection. So if you have an infection, you might have heard about torch infection. Syphilis being one of those can cause a nephrotic syndrome in babies. Okay. All right, so primary nephrotic syndrome can be idiopathic, and one of the major entity in the idiopathic group is minimal change disease. Other two includes the FSGS that we spoke about before and membranous proliferative. Minimal change disease being the major entity in children, it accounts for 90% of cases between ages 1 and 10. All right, so the 1 to 10 age group is the minimal age group. Less than 1, we talk about the congenital types and the infectious type, and over 10, other entities come into place. Minimal change account for 50% of children over 10. So if you have a child between 1 and 10, and they were diagnosed with nephrotic syndrome, it's likely that it's going to be minimal change disease. With respect to incidence, it occurs in 3 per 100,000 children per year. That might not sound like a lot, but if we look at Jamaica population, right, you know, that might translate to about 60, you know, per year, which, you know, add up to quite a bit. The male to female preponderance is a 2-to-1 ratio. 80% of the patients with nephrotic syndrome will have minimal change disease, and 50% will have FSGS before the age of 6. So most of the patients with nephrotic syndrome are going to present before age 6. In terms of the clinical features, the most notorious feature that the parents are going to present with, or the children are going to present with, is swelling around the eyes early in the morning. So the patient wakes up in the morning, the mother notices that the eyes are a little puffy and swollen. The baby gets up, he walks around the house. By the end of the day, the swelling is gone. By the following morning, the swelling recurs and it gets worse and worse until, you know, the swelling around the eyes become persistent and they start noticing swelling to the rest of the body. Of course, swelling to the eyes can be due to allergies, sinus problems, you know, stuff like those. But the classic pattern to nephrotic syndrome swelling in children is that they get the swelling around the eyes, improves throughout the day, and progressively worsen. Most of our children present with a progressive worsening, where they have swelling to the rest of the body, swelling to the feet later on, you know, and then they start having swelling, fluid in the pleural cavity that is around the lung, and they're presenting with shortness of breath. And then some of them start presenting with swelling around the peritoneal cavity that is in the abdomen, the belly, and they present with what is called ascites. Anasarca is generalized edema, meaning you're swelling on the face, all over the body. Usually in nephrotic syndrome, the blood pressure is normal, meaning in minimal change disease. Other complicated forms of nephrotic syndrome, you can get an elevated blood pressure, but in the simple classic minimal change disease, that don't usually present with blood pressure. And of course, this is important for nurses. The blood pressure needs to be checked because early in minimal change disease, because of the dehydration. So be aware of a child who comes in and he's very swollen from head to toe. The problem is that when, you know, a doctor or a nurse may see this child with edema, they may assume that this child cannot be dehydrated, right? But if you don't assess dehydration in this swollen child properly, the child can end up having kidney failure. So what that means is that most of the fluid that is in this baby's body is on the outside. So that is why the eyes look puffy, the face look puffy, they're big and swollen. But when you check their blood pressure and you check their pulse, there's actually no fluid in the inside of the blood, called the intravascular compartment. Hematuria is not seen in minimal change disease, right? So in other kidney conditions, you may see red urine or what we call Pepsi-colored urine or tea-colored urine. This should not occur in minimal change disease. If you see that, you have to think something else is going on. So the nurses are usually going to be checking the urine, you know, doing a dipstick, looking at the gross color of it. The other thing that the parents may discuss is that the child presents with a frothy urine. So because there is so much protein in the urine appears frothy, right? So with minimal change disease, right, the parents will tell you that, you know, the baby's urine looks very frothy. In terms of complications, they are at risk for developing infections caused by encapsulated organisms. Encapsulated organisms are bacteria that has a little mucopolysaccharide rim around it, right? That protects it from getting destroyed by the immune system. What happened is that in minimal change disease, nephrotic syndrome in general, they lose proteins such as albumin, which cause them to be swollen and puffy, but they also use certain proteins that are important in the immune response. So they lose immunoglobulins, and they lose a protein called properdin. And what properdin does is that it forms holes, or help the immune system to form holes inside certain bacteria and kill them. So if we're losing those proteins in the urine, then the patient is going, the bacteria is going to free flow, and the patient is going to be at risk for these encapsulated organisms. And hence they develop what is called spontaneous bacterial peritonitis. Basically, you have an infection around the membranes surrounding the bowel. So the patient may present with distended belly, may present with a tender abdomen that the nurses, in their care can observe for and can pick up when you examine the child. They can also present with thromboembolic phenomena. So another thing that is lost in the urine is what is called antithrombin 3. All right, it's called antithrombin 3. So with antithrombin 3, what happens is that antithrombin prevents clot from being formed in the body. So if you're losing antithrombin 3, then the body is going to form clots inside the blood vessels. So you form these clots, and then they get dislodged, and they go to the brain, and you can get a stroke, or they go to the lung, and you can get a pulmonary embolism, or you can just get clots in the leg, in the blood vessels of the brain, and develop serious neurological problems. All right. They develop what is called a hypercoagulable state. So basically, the thickness of the blood, what is called the viscosity of the blood, increases. And this is related to the fact that they are dehydrated, so there's less water in the blood. And also, when you have nephrotic syndrome, because you're losing the proteins, your body sends information to the liver to make more protein. Some of these proteins that are made includes your lipoproteins, which are your lipid, your HDL and your LDL, and cholesterol and those things. And those additionally makes the blood viscous. Of course, those things are going to put the patient at risk for plaque formation. So we have to monitor those as well. If the patient's hydration status is not picked up adequately, the patient is going to have kidney failure, what we call acute kidney injury, because there's no blood flowing through the kidney, so the kidney is going to go into failure. So you have to pick up, check the pulse. If you see a patient big and swollen, you can look at his mucous membranes, check his pulse first. Yeah, look inside his mouth to make sure, but don't look at his external feature and say he's not dehydrated because he looks so swollen. As swollen as they look, a lot of them actually are dehydrated and needs to get fluid in the appropriate context. Skin necrosis is important for nurses as well, and skin infection. We had a child who was so swollen that, his skin got broken down, right, and got infected. And of course, if the patient is not managed quickly, urgently, and properly, they can succumb to the disease. All right, so in terms of investigations, there are general and specific investigations that we do on these patients. You do investigations to confirm your diagnosis and to rule out other secondary causes. You need to look at their blood count, their CBC as we call it, looking at their hemoglobin. The patient can be anemic from sickle cell disease or from other chronic disease condition. Look at their white cell count. They are at risk for infection. If you get a child who has a very high white cell count, they need to be sorted out properly. The platelet count, if they have, what we call DIC, meaning the blood is forming clots, the platelet count will also be low. UANEs, the medical people, know about that. The non-medical people, their kidney function. We need to check to make sure their kidneys are functioning properly, we need to check their lipids, right? And remember, when you do the lipids, you have to do a fasting lipids, right? So you don't do just sit randomly. You need to do your lipids before a meal. What is called your C3, these are proteins inside the blood that can give an indication that, you know, probably some autoimmune disease is happening. You need to check their HB electrophoresis, that's for sickle cell disease. Certain infections such as HTLV1, hepatitis B and C, as we mentioned before, and certainly HIV. The ASTO that will check for your strep sore throat infection, and ANA is also for lupus. I will mention VDRL already. They may do a throat swab as indicated, because we know that strep sore throat can cause a nephrotic syndrome picture. For the nurses, the urine is important. So we do a urine dipstick, and it's an early morning dipstick before the patient becomes ambulant. Once the patient starts walking around, that is not a very reliable sample, because the urine is going, everybody passes some protein in the urine when they walk around. So you're supposed to check that very first urine sample before the child starts ambulating. Of course, you're going to send to the lab for a urinalysis, right? And the urinalysis is going to check for, you know, any blood in the urine, any cast, you know, and stuff like those. And most importantly, nurses, in children, we no longer do 24-hour urine collection for protein. So this is one of the most important diagnostic tools for nephrotic syndrome. We need to check what their protein levels are, both in their blood, which is going to be low, and next in their urine, which is expected to be high. So instead of doing the 24-hour urine collection, which we used to do in the past, which is very unreliable for children, because, you know, they pee in their pamper, you know, they got to do, and they pee as well. So you're going to lose out some, it's not going to be very accurate. So a simple test that we do is what is called a spot urine to protein, spot urine protein to creatinine ratio. So we just take one single sample in the morning, send it to the lab, and if the spot urine protein to creatinine is greater than 2, the patient has nephrotic syndrome, right? So you don't have to worry anymore about that 24-hour collection that we used to do in the past. As we wrap up, the management, diet is very important. I think somebody later will be talking about nutritional support in nephrotic syndrome, but we don't, you might be tempted, knee-jerk response to think that if the patient has nephrotic syndrome and he has a low protein, the thing to do is to give them back protein, right? So that's not what we do. If you give them protein, it's going to spill out again. So we don't do a high protein diet. We do a normal protein diet. We don't give them, you know, we give them a no added salt diet. So basically maintenance sodium. Their fluid must not be restricted, because you're going to send their kidney into shock. So you must give them maintenance fluid based on their dry weight. And what I mean by their dry weight, when that patient is big and swollen and you measure their weight, the weight is going to be a reflection of the fluid that is in their extravascular space, right? So you're not getting a true weight. So you need to, yeah, you know, you have estimates that you can use for the dry weight, but if you have a weight that you had on them before, you know, you can use that. But there are ways that you can, you know, do an estimate of the dry weight. You're going to do their input and output charting. All the urine passed need to be collected and checked, measured properly. Pour it out in a container. Don't just measure it in the bag. You're going to do an early morning urine dipstick, as we said before. You're going to do their management of their swelling, which is edema. For the edema, if it's just mild, we do supportive care, right? If it's moderate, we give them a medication called spironolactone, right? If it's severe, then this is where the nurses are going to come in now. We give them albumin, right? Along with Lasix, but we don't want to overload them, right? So you notice that we don't just give plain fluid, like plain normal saline or plain lactated ringer. If we give those, it's going to leak right back out, right? So we give them, albumin, and that will help to pull back some fluid into the intravascular or into the blood vessel space itself. Management include management of the skin, right? Which you guys are going to be very critical in managing, turning the patient regularly every 2 hours, especially if they're very sick and not able to, move a lot, using various padding and that sort of thing to protect the integrity of the skin, bathing them. If you have breaches in the skin, managing those appropriately, because, they're at risk for infection because they're losing their immune properties. So we need to manage the skin properly to prevent further infection that might enter through the skin. All right, the treatment now for minimal change disease, what the definitive treatment is with steroids. And the specific steroid that we use is called prednisone. We give prednisone at a dose of 2 milligrams per kilograms for children. And it's to a maximum of, say, 60 milligrams per day. It's a high dose steroid, and we know steroid has its side effects, but that is what is used for children, 2 per kilogram per day. We give them that for 6 consecutive weeks, every day for 6 weeks. This is followed by the same 2 milligram per kilogram. We give them alternate days for an additional 6 weeks, right? So the same dose is given for continuous 6 weeks. Then the next 6 weeks, we give them it every other day for 6 more weeks. And then we discontinue it or taper it over 2 to 5 months. And we should be made very aware of the fact that we cannot stop steroids abruptly, right? We have had a child who the mother took her home. She decided she's going to stop the steroids. And this is a part of our counseling, which we'll talk about in the next few slides. If she stops it right away, the child can get an adrenal crisis and collapse, right? So this child, his blood pressure fell. He became very sick and toxic because he stopped the prednisone too quickly. Prednisone cannot be stopped. The high dose one, especially if they're on it for over 2 weeks, it needs to be weaned, meaning we need to bring it down slowly every week until it's discontinued. There are other drugs that are used, and you just need to be aware of these. When we get to this stage, we usually refer them to the nephrologist. They're not responding to your steroids, they're not behaving typical. They might need to be placed on other immune modulating drugs, such as your cyclophosphamide, cyclosporine, mycophenolate, your ACE inhibitors, and of course, we refer them to the nephrologist. Further follow-up, education is critical for the nurses. You need to teach them how to test the urine, and there are 2 ways that we do it. You can use your sulfur salicylic acid, what we refer to as SSA, and basically it's a fluid that will be provided by the pharmacist, where we mix the urine with the SSA. If there's protein in it, it becomes cloudy. And what we do is put it in a container and mark an X on a paper, put the container over the X. When we add the salicylic acid to the urine, if it's very cloudy, the X will disappear and we know that the patient has protein and has relapsed. All right, so that's what you can teach them to do at home. The other method is that we have been giving them the dipstick. So they take the dipstick home, they dip the urine, and they read it off themselves. So therefore, as caregivers, we have to explain to them, demonstrate to them, let them demonstrate to us how to utilize these methods, because when they go home, they're going to have to be monitoring their proteins at home, because if they start spilling again, they need to come back right away. All right. Vaccinations are important. You might have guessed it. We're going to put them on steroids. So they need to get certain vaccines, such as the pneumococcal vaccine. And furthermore, they're losing certain proteins, so they're at risk for pneumococcal disease. That is a bacteria called strep pneumonia. Note, however, that if a child is on prednisone at 2 milligrams per kilograms for greater than 1 week, do not give them live vaccines. So they're not supposed to get measles, mumps, and rubella. They're not supposed to get influenza, which are the live vaccine, rotavirus, varicella, those are all live vaccines. The patient is not to get those if they're on high dose steroid for greater than a week. And definitely they must be off it for 3 months before you give them live vaccines, because you can give live vaccines and the patient actually get the disease from the vaccine. Further follow-up, advise the patient about infections while on steroids, and you need to be very meticulous with that. Remember, if you're on steroids, your immune system is going to be suppressed. So those patients are not going to present with, a florid pneumonia with cough and cold and looking very ill. They might have pneumonia taking up their whole lung, and they sit in front of you and they look well, right? Because their immune system is not fighting the infection floridly, and a lot of the side effects that we have from an infection is due to our immune system trying to fight the medication. They might not have a fever, right? So patients on steroid, you need to, if they just look a little sick, the child says not feeling so well, mommy says not eating, those are the things you look at, not the fever and the breathing short and that sort of thing. They can be very sick and don't show much signs, all right? Encourage and support access to system to support them socially and financially. The PATH program, the NHF, system, all of those things, that we need to support them. Psychosocial support for the parents, the child, and especially the teenagers. Very difficult for them. They feel different. They have to be taking this medication. Sometimes they become very obese because of the side effects of the steroids. And we have to, support and encourage them along those lines. So I've come to an end. So in summary, minimal change disease is the most common cause of nephrotic syndrome in children. Thankfully, it has a very good prognosis. As I said before, 90% of the children and even adults recovers completely from nephrotic syndrome. Remember I told you about my child who got the medication. He recovered completely and has never had it before. But I have some children, especially some older children, who they get relapses very frequently, right? And that can be very frustrating. But in general, it has a good prognosis. Taking an appropriate history, doing your thorough physical examination, and treating the patient appropriately will reduce the risk of a lot of the complications that we spoke about and the long-term side effects of medication. Nurses, you are very critical in the care of children with nephrotic syndrome. With adequate nursing care and a multidisciplinary approach to management, the outcome of our children is usually exceptional. And at Mapen Hospital, we haven't, and I'm sure it's the case in Jamaica, I can't recall us having any deaths at all from nephrotic syndrome. All right, so follow-up and support is critical, showing them how to do their testing, keeping a tab on them, what is going on at home, making sure they're taking their medication and monitoring for the side effects of the medication. And of course, exploring the socioeconomic factors is very critical to the management. So this is what we are we are usually present with a child with minimal change disease, a very sick looking child. We see all of the fluid in his belly, his face, is just very overloaded extravascularly with edema. And that's him leaving for home, right? It's not the same patient. These are just an example. And I want to thank you very much. These are my references. And thank you.
Thank you, Dr. Price. Knowledge is power. And so as healthcare workers on this field, medical, nursing personnel, and even parents, some of us are faced with these challenges with our children having nephrotic syndrome or know of family members with nephrotic syndrome. And so we really appreciate the knowledge today, the reinforcement of management all of the information that was presented to us. So excellent presentation, sir. I have any questions for our participants, sir? Would you like to ask them anything just to reiterate what you had just taught us? Or does any of our participants have any questions for Dr. Price? Please indicate by raising your hand in the chat. We will, or raising your hand, we will. Okay, so I'm seeing persons saying, Marcel saying, thank you, Dr. Price, great presentation, lesson. So you're getting a lot of things, Dr. Price, and you seem to have a lot of favorites on here. Very pleasant and informative presentation. Thank you, participants, for sharing and for thanking our doctor for so ably presenting nephrotic syndrome in children. And so, since we don't have any further questions for doctor, or he doesn't have any questions for us, we will move right into our next presenter, who is waiting. So we thank you again, Dr. Price. Thank you so very much for your presentation. And we hope that you will stay with us for the remainder of the seminar. If you can, we will really appreciate your presence with us. As we continue the seminar, we will have a follow-up to Dr. Price's presentation in the afternoon with our dietitian. So our dietitian will come in at 2 o'clock to tell us or to teach us how to treat our nephrotic or patients and our relatives who have nephrotic syndrome, what type of diets, how to manage their diet. So we will have a follow-up to Dr. Price's presentation in the afternoon. All right, so thanks again, Dr. Price, and we welcome our DNS, Mrs. Yvonne Brown-Smith, our Director of Nursing Services from Mayfair Hospital. We welcome you, ma'am, as you come to us with nurses documentation. And that is one of our sore points in hospital. Some of us don't like to write. And so we look forward to hearing Matron Smith's presentation on documentation. Welcome, Matron Smith.
Thank you.
Matron?
Yes, I'm here.
Welcome. Good morning to you.
Good morning.
And thank you for accepting our invitation, and we look forward to hearing your presentation. All right.
Okay, good morning to everyone. And let me acknowledge our incoming president, Mrs. Clark Wall, and her team for putting to be able to provide the curve documentation, pay the curve documentation, identify the key method of documentation, make public guidelines of documentation, also identify laws documentation. First, or here or the service provided.
Good morning, Matron Smith.
Hello.
Okay, your audio quality is a bit poor. I'm not sure. Are you hearing me? Matron Smith? Yes, other participants in the chat, they're saying that Your audio is not clear. I'm also not hearing you clearly. All right. You can speak again. Go ahead. All right. The audio quality is very poor. I don't know if we can shift the microphone, the device, just bring it a bit closer, just to see if we can hear you better. Yes, I'm hearing you a little better, but yes, the audio is still not the best, but I'm hearing you a little better. Yes, it's a bit muffled. Sure. All right, you can speak again. Go ahead. All right, the audio quality is very poor.
Oh, not hearing. I'm not sure what's happening with the headset.
Okay, I'm hearing you better now. Yes, I'm hearing you
You're
better.
hearing me now?
Yes, great. I'm hearing you now. Hearing you very clear.
All right,
Yes, go
sorry
ahead.
about that, team. So we were at the definition of documentation, and we say it is any written or electronically generated information about a client that describes the care or the service provided to that client. Right? And through documentation, nurses communicate their observation, decisions, their actions, and the outcomes of these actions. And let me emphasize that documentation, it must be an accurate account of what occurred and when it occurred. All right, so we say, what are the purposes of documentation? It facilitates communication, and we all know that once the nurse documents about the patient, the information about the patient, in the nurse's notes, it will be read by other individuals and care providers, and it will tell you about the status of the client, the nursing interventions that were carried out, and the results of the intervention. And it also increased the likelihood that the client will receive consistent and informed care or service. Another purpose of documentation is that it promotes good nursing care. So
Okay,
we say,
hello?
hello?
Yes, sorry to interject. Are you moving the slide?
Yes, I am.
Okay, it's still at slide 1. So probably you can stop share and start share. Just reshare and skip through. Let me just confirm that the slides are actually moving. All right, so you can stop. Yes,
stop
and
share.
Yes, and go ahead again.
And start sharing again.
Yes.
Are you seeing the slides now?
Yes, I'm seeing the slide. Could you skip to the other slide? Just let me just confirm that it's actually moving. All right, yes, it's moving now. So you can operate it like that. You can continue. All right, thank you very much.
All right, thank you too.
You're welcome.
All right, so we were, okay. We were at the purposes of documentation, and the first, okay, we were at the purposes of documentation, and we said that the first purpose was it facilitates communication, that the nurses' notes would communicate to other care providers, the assessment on the status of the client, the nursing interventions that were carried out, and the results of the intervention. It also increased the likelihood that the client will receive consistent and informed care or service. Secondly, it promotes good nursing care. And in promoting good nursing care, the nurses assess the progress and they determine the intervention and to say how effective or ineffective those interventions were. And it also identifies and documents changes to the plan of care as you go along. Documentation too, we say it can be a valuable source of data in that nurses can use the outcome of the information from a critical incident to reflect their practice and make needed changes based on evidence. Thirdly, it meets professional and legal standard. So in meeting the professional standard, the nurse-client relationship, the nurse has applied the knowledge, the skills, and the judgment according to her professional standard. In meeting the legal standard now, it is used in the court of law, and in the court of law, it is compared to the standards of a prudent nurse or with similar education and experience. So when we have issues like patient complaint and they would ask for evidence or they ask for the medical record of the client, remember now is the entire medical record that is copied and sent to the court of law. It is not the 24-hour report. So all documentation that are made by all the nurses are sent to the court of law. And in the legal part of it, they will ask for summaries from the nurses' notes from the directors, and we have to see if the standard of care was carried out. Okay, our next objective was to identify the method of nursing documentation. So we have 3 methods here that we can use in documentation: focus charting, SOAP, SOAPIRE, and everyone is familiar with that one, and also narrative documentation. In focus charting, you focus on you assess your client, your interventions are carried out, and you say the impact of the intervention on the client's outcome, or they are organized under the headings of collect your data, do the actions, and the response. So in collecting the data, it is a subjective or objective information that is supported, and it is focused, and it describes the client's status and the time of the significant event or the intervention. The action, so you say whether the action that you planned was carried out, was completed, or the nursing intervention was done, and the nursing assessment of the client's status. The response you get from the action is that if there was the impact that you get from the response, from the action, is that they tell about the client's outcome. And you can use also the flow sheets and checklists as adjunct documents to these response. So we use like the vital sign chart, intake and output. We use the fluid balance charts, right? These are recorded on, they say flow sheets or a checklist as in relation to the actions that we're doing. SOAPI or SOAPIRE method. It is a problem-oriented approach to documentation where you identify and you list the client problem, and then it following according to the identified problem. It is generally organized according to the following headings. S, subjective data, and this is how the clients feel. Objective data, it is as a result of what you see, your examination, your findings. Assessment, what is the client's status? How is the client doing this morning? What did you see happening with the patient this morning? Plan, what you intend to do to make the changes to this patient or client. And your intervention, what occurred? What did the nurse do? Was the intervention successful? Is there need to be a change, right? And afterward, you evaluate. You evaluate the client outcome following the intervention. So elevated temperature, you evaluate at the end. Did the temperature reduce, or you need to reassess and do another plan of action? Also, revision. What changes are needed to the care of the plan? Similar to focus charting, flow sheets and checklists are frequently used, and we use our flow sheets are like temperature chart as before, blood pressure charting, fluid balance charting, etc. We also have narrative charting, and this is a method where the nursing intervention and the impact of the intervention of the client's outcome are recorded in a chronological order, right? Covering specific time frame. And we know that data that is recorded in the progress notes is often without an organized framework. Narratives charting, it may also stand alone, or it may be complemented by other tools, as we said before, with the temperature charts, fluid balance chart, blood pressure charts, or a checklist. So the guidelines for documentation: write legibly in ink, no pencil, and the paper, it must be, the ink must.
Excuse me, Matron Smith.
Yes.
What slide are you at?
I am.
Because we're still at objectives. Slide 2.
But I thought you said they were changing.
Yes, in the initial stage, it was changing, and so I'm seeing where.
But it's not. Oh Lord.
What you could do, you could put it in slideshow and just use
it is in slideshow. It is in slideshow.
Okay, so what slide are you at right now?
I am at slide.
Is it you?
All right, so you can just confirm what
Are
slide
you seeing any? Are you seeing it now?
Yes, I'm seeing the screen, and it's at slide 2, objectives.
Slide.
Yeah. But what you could do though, because I'm seeing the side panel, you could just press the down key, and by just pressing the down key, it will.
The down arrow?
Yeah, the down
That's
arrow.
what I've been doing.
Okay, it's not moving.
It's not moving.
No, it's not moving. What you can do, all right, go to from the beginning. At the top, you see from beginning.
From beginning.
To the left corner of the screen at the top. That's to go in full screen. All right, so I'm no longer seeing. Okay, it's coming up. It's coming up. Okay, just. All right, so you can press the arrow key, back or forward.
Yes.
Just to go back, go to the slide that you're currently at. So you can use the arrow key now. Press. Okay, I have a lot of transition on the slide. So
you're seeing.
It's gonna take some time for you to go between slides because of the transition. All right, I tell you what to do. Easy. Press the escape key on the computer. ESC.
Yes.
Okay. All right. Okay. I'm not seeing. Okay, it's coming up now. I guess your computer is a bit slow. All right. So you're gonna work between the side panel, right? You're now at slide 18. So press the down
Yes, slide
key.
18.
All right, press the down key now. You should move to the, no, just press, no, don't click. Just press the down key. Don't click. Don't click. Don't use the mouse. Just press the
Okay.
down key. Down. Arrow down.
Yes, that's what I'm doing.
All right. So you're going to interplay. You're going to use the arrow up and arrow down to operate the slide. So you can go to the previous slide where you were now and use the down arrow to continue go through the presentation.
Oh boy.
Yes.
I'm sorry about that. Didn't know that the slides were not changing.
No problem. No problem. That's how it is sometimes. We all need learning.
Oh boy, I
Yes.
guess this is it's not a modern computer at work. So we were
Alright,
at
so
the guidelines for documentation. Are you seeing the slides now?
Yes, I'm seeing it. So you can continue.
Okay, thank you. So
You're welcome.
All right, so our guidelines for documentation, write legibly in ink, not pencil, and it must be paper, it must be a paper-based system, right? If you write words that are misspelled, they can give wrong interpretation of your information. So ensure that you make your words are spelled correctly, right? And their writing is legibly. Of note, you must sign all entries. And nurses know that their signature needs to be identifiable, and also they must write their title at the end of each entry. If initials, that means your institution must have a record system that can identify the care provider. Example, our drugs chart. On the drug chart, at the bottom of it, you will write out your name and your initial. So when you administer your medication, because of the space that we have to put in our initial, it is small, so you can't write your full name. So you write your initial when you administer the medication. But at the bottom of the chart, you will see where they ask you to write your name and your initial. So anyone who comes along can know who administered this medication. You must document on the agency form. So we have forms that are out of the Ministry of Health and Wellness. Any form that is created, it is not a legal form. And so it is not stored by our medical record department because it is not originate out of the Ministry of Health and Wellness. You must use appropriate abbreviations. And I must tell you, I am seeing a lot of abbreviations coming across now on the 24-hour report, which I have to call and get clarity because I don't know those abbreviations. Some of them are not medically approved, but yet still the nurses will continue using the abbreviations that are not approved. Correct the errors. Usual practice in correcting an error in your documentation is to draw a single line through the error and make a notation, right? And your initial. You then record the correct entry alongside where you draw the line through that error. You record the correct entry alongside on the page, and then you don't put it on top of the cross out entry, right? And you must not use whiteout, erasers, and you must not, I said, make the entries between the lines. Also, another guideline is to document in chronological order with the correct time and the date for entry. When you're making a late entry, you must put late entry, put the date and the time and that observation was made or the care that was given. Document concurrently or as close as possible to the time care was given, right? So that it can be in a chronological order. You don't want to do a task at 10 o'clock and then you're making your entry at 2 p.m. Try as best as possible to make your entry as soon as the task is done so that you can have the correct time noted on the medical record. Yes, so when we delay in making those entries, it can cause omission, errors, inaccuracy, because you might not remember. So we have memory lapse. And pooling observation to record at the end of the nurse's shift is not recommended. Another guideline is to write constant using different times. You're documenting, right? Do not say the client slept for 3 hours to 5. Exactly what the patient did. It is not necessary to repeat the information that is stated elsewhere in the health record, such as on the flow sheet. So if you do your temperature charting and your blood pressure charting on the required chart, there's no need for you to write it again in the nursing. It's repeated. Practice issues are not documented in the health record. Example, in the previous nurse's notes, one entry that was made in the notes was that the patient eat like a horse. No, we do not label the client. We do not use those terms in the medical record of the patient. You document only from first-hand knowledge so that it is what you see, what you do, and what was reported to you, you can. Except in an emergency, such as a cardiac arrest, where you have a team of persons providing the care for the patient, then you will have somebody who is documenting the information, right? That is the care that is being given at the time. They said that the care provided by the auxiliary staff is documented by the auxiliary staff, but not so in our system. What they do, they would document, like here at Maypen Hospital, when they do their rounds and they empty their urine bags, they would document in a book, and then the nurse would get the information from that book to put in the nurse's notes. So we don't allow them to document in the nurse's notes. Another guideline is to safeguard the confidentiality of documentation, and we cannot overemphasize confidentiality of the nurse's notes or the medical record of the patient, right? So you must only disclose confidential information to authorized persons, right? Unless there is a risk involved and you have to share it with other team members. So the fact was to identify the flaws in documentation. We said that before, we do not use erasers, we do not use whiteout in documentation because it's a legal document. Pathology reports or diagnostic test findings that don't correlate with the physical assessment findings or that do not show the medical necessity for a procedure. Sometimes too, you have misplacement of diagnostic charts or test findings they are put on another patient's record. And when you look at it, you realize that this does not add up. It does not speak about this patient's condition. So we must try to avoid all those flaws. Okay, that was my final slide. And these are my references. Any questions?
Thank you. Thank you so very much, Nathan Smith. Excellent presentation. Documentation. Wow. If it's not ready, it's not done. And so delay is danger. And so we thank you so much for your presentation, for reminding us how important it is to document everything that is important to the patient that we do and the right timing. So thank you so very much. Any questions for our formation? Any more participants? Any questions? Or do you have any questions for our participants? Matron Smith, do you have any questions for our participants?
No, not at this
Okay.
time.
I see a raised hand. You want to open up first? Okay, so Shauna has a question. Go ahead, Shauna, with your question.
Afternoon.
Shauna, you can unmute and ask.
Okay, hearing me now?
Hi, Shauna.
Yes, afternoon. Matron Smith question. With regarding to the late entry, usually you would write the late entry in the slot. Some persons would write it where the time would go and then put the time across where the nurse's note would be written. Is that accepted, or we should still put the same date and time in the provided slots and then put late entry beside the entry itself?
Okay, yes. What you should do is the date and time slot is already there. So you put your date and time, you go over into the nurse's note section, put late entry, and then you make your entry.
Okay, thank you.
Don't confuse by putting late entry in the date and time area, and then you put the time in the nurse's notes area.
Okay, thank you.
Welcome.
Thank you, Shauna. Excellent question. Thank you. Any other? Please indicate by raising your hand. If you have anyone with any other question? Shauna, you may take your hand down, please. All right. So we thank you again, Nathan Smith, for your presentation and for joining us today at our seminar. We really appreciate
This is
your
Faith
presentation.
Israel. This is Faith
Thanks again.
Israel. This is Faith Israel.
Enjoy the rest of the seminar. All right, so we're coming down. It's midday. Good afternoon to our participants. You have been great. Thank you so much for staying with us. So just before we go to our lunch break, we have two short presentations from two of our sponsors. That would be Orion Insurance Brokers, that Miss Veronica Williams, she'll be coming to us for a few minutes, and then we will have another presentation, a short presentation from Industrial Life Services. And those two presentations are really short presentations, and then we will go into lunch. But I think there's another question in the chat. It says, question information, if a child, Mason Smith, are you still there? I'm gonna read this question for you. If a child was fed apple juice, and this is documented on the feed chart, does this need to be written in the nurse's notes as well?
No.
Question. Matron Smith? Okay. Go ahead and respond, Matron. Would you like me to read the question again? Yes. Okay, the question says, if a child was fed with apple juice, and this is documented on the feed chart, does this need to be written in the nurse's notes as well? All right, so I'm not sure if Nurse Smith is Matron Smith is hearing us, but we can go ahead and respond to that. My take would be, there's no harm in recording it in the nurse's notes as well. Sometimes the feed chart get misplaced, as one of our participants mentioned in the group, in the chat, that sometimes the feed chart get misplaced. And so we should always, it doesn't harm us to just write it again in the nurse's notes. At least you know that it is written twice. All right, so thank you. Thank you, Nurse Wright, for your question. Thank you, Nurse Blair, for your response to Nurse Wright's question. Thank you so much. So I think we're going to invite now Miss Williams, Mrs. Veronica Williams from Orion Insurance Brokers to share with us. They are one of our sponsors for today. And so Mrs. Williams, we thank you so much from Orion Brokers. Thank you so much. You've always been partnering with the Enrolled Nurses Association. We really appreciate you, appreciate what you do for us and your continued support. Thank you, ma'am. And please go right ahead with your presentation. Go ahead and unmute, Mrs. Williams. Williams?
Oops. Hello? Hello? Are you hearing me? I'm not sure what is happening.
Yes, good evening. Sorry, good afternoon. This is,
Afternoon.
yes, we are hearing you. So you can go ahead now.
Okay. All right.
Yes,
Thank you
yes.
so very much.
All right.
Right. I want to say thank you for this, for the invitation and the continued partnership that I have with the Enrolled Nurses Association. It's always my pleasure to be in your presence and for my company to be represented in this way. And I want to say a big thank you to all the organizers who organize this wonderful program. And I'm happy to see the amount of participants. You know, it's wonderful, over 200 persons. And a special thank you to Ms. Claudette Clark-Wall for this invitation as well. No, as she was mentioned, Veronica Edwards-Williams, Orion Insurance Brokers, and it's always a pleasure for us to partner with you. And this afternoon, I will be presenting, and I'm sure lots of persons on this platform are, and I hope are aware of the Orion product. It's a life insurance group plan that provide coverage for all medical personnel. It's a wonderful insurance plan that a lot of persons have benefited and continue to benefit from. As I stated, it gives you life insurance coverage, accidental dismemberment, accidental medical reimbursement, and accidental sickness benefit. Well, a lot of persons are aware of the accidental dismemberment and accidental medical reimbursement. And now we're in full force again with the sickness medical reimbursement. So if you might become ill for whatever reason and you're off the job for over 14 days, for any illness, you might do an operation, no, where you're able to benefit from that plan that is being offered. And if you meet in an accident, you can claim back for medical expenses, as well as you get an income while you're off the job. And our products are not very expensive. If it's just for you alone, the plan starts at as small as $1,000 per month. If you have your parents and your parents-in-law, you can also add them to the plan just for coverage. In case of death, you don't have to worry yourself much because sometimes your parents are not ill and you have time to prepare. Things will happen suddenly and you can rest assured that you have a plan through Orion Insurance Brokers to take care of those final expenses, as well as for yourself that you're probably at work, walking along the corridors, not realizing that water is on the ground, you might slip and hurt yourself. You're here caring for the patients and we're here caring for you. So you might fall and you sprain your leg, you break a leg. You're at home feeling young, want to go pick some mango, it's mango season. No, you miss a step, fall, something happen, you're unable to go back out to work. You can't do the session to help take care of your monthly bills. Here at Orion, we have our plan cover for you. You can be on sick leave for up to 2 years. And based on what the sick leave certificate says, you would be compensated for the time that you're off the job. The first 14 days is not counted, but anything after that, the full amount will be paid. We have upgraded our plans, guys. We have upgraded our plans. Cost of living has gone up, and so must the benefit that you get need to go up as well, but we try our best to ensure that we maintain your premium at the original cost. So before, the maximum amount that was paid out was $80,000. Now you can get up to $300,000 in your income benefit, as well as your accidental medical reimbursement. And I'm sure for all the persons who are already on the plan, that is wonderful news, guys, right? And it's not hard for anybody to enroll. If you have further questions, I know my time is short. I'm trying to just, get everything in. I know you have your pen and paper. You can write my number down, 833-4394. That's 833-4394. If you have further questions that you would like to ask, you can always drop me a line, a WhatsApp, and I am here to answer all your questions. And no, if it's possible, I don't know the time, you could probably drop a question in the section here, and I'll try my best to answer them in the chat. All right. And one other most important thing that I always love to encourage person, it has a saving component to our plan as well, where you can start as low as $500 a month to as much as you can afford to save. As what we would normally say, save for the rainy day, and the rainy day will never present itself because you have something put down. And everybody who saved with Orion, they're always happy. The returns are excellent. And the ease, you don't have to, anywhere you find yourself in Jamaica, you don't have to leave your home, you don't have to leave the hospital. You can do the withdrawal. It's done electronically at ease, at your own leisure. If you leave one hospital, meaning you leave one region to another, you can still maintain the plan. We just move from region. And if, as what has been happening, a lot of our nurses are migrating, and I tell you, they all keep their plan because it's an excellent plan, and they stay overseas and they still maintain the coverage plan that they have with us and operate as if you're still here. Do withdrawals and send funds locally to their family members, and any benefits to be paid, it's paid out just the same. Only difference, as I would always say, is just the conversion from Jamaican to US dollars. So for persons who are probably at that stage where they're thinking about migrating and they're already on the plan, or this sounds so good and they want to be on it, but I'm about to leave, fret not yourself. The benefits will go with you anywhere you find yourself in this world. All right, so I will repeat my number again. It is 876-833-4394. That's my number, Veronica Edwards Williams. All right, so 833-4394. And I am currently at the Spanish Town branch. I work to Mandeville, St. Thomas, and as I said, it doesn't matter anywhere you are in Jamaica, we will get to you. All right, I hope I've not gone over my time. I want to thank you all so very much for this wonderful opportunity, as always, as we have and continue to have this wonderful family relationship that I have with your association. All right, I want to thank you once again. All right, and I will continue to be a part of this wonderful program today. Thank you so very much, guys. Remember, any question, you can send them on the chat, or you can just give me a call or WhatsApp me. Thank you so very much.
Good day, everyone. I'm not sure if I should go ahead. Okay, no problem. I'm Trevor Lewis from Indus Life Sciences. Let me just share my screen quickly. All right, so can you confirm if you're seeing it for me? All right, so seeing the screen, and is it switching? All right, I think I seen yes in the chat. Okay, no problem. All right, so I'm from Indus, and what we aim to do is to enrich lives through better products. And I do thank Mrs. Clark Waugh for the invitation. And I want to say a big shout out to all the nurses. I say over 200. And just to commend you all, because you're an important part of our healthcare system. All right, so one of the products that we have treats neuropathic pain. So what that actually is it's the pain experience when the nervous system isn't operating as how it should. And the name of the product that we have is Neurobalin. So what Neurobalin is, it's a pregabalin formulation, and we have it in the 75 milligram strength and the 150. So it's available in pharmacies everywhere in Jamaica right now. So this is a product that the patient can get. And the cost is, our cost is very affordable and compared to the others. And it is also subsidized by the NHF, both the 75 and the 150 milligram. And just to show you what after the subsidization, what it looks like, when the patient goes to the pharmacy and the cost is, let's say, 3,394 here, the NHF takes off 3,225. So they only pay, if my maths is correct, about $170. So call it $200, and that's for 30 tablets, which is a month's worth. So it is very affordable for your patient. And especially since they are chronic patients and they're always on these products from month to month, year over year. All right, so I have another product, and this is essential for daily life, sustaining the body and everything. So there are 5 main things that you should do to maintain a nutritious, healthy body. And that's exercise, eat nutritious foods, drink water adequately, get more sleep. I know we lack that many times. And most importantly, take amino pep. So why is amino pep the choice? We have all the essential amino acids, as well as vitamins, minerals, zinc, calcium, and highlighted here in red are the essential amino acids. So what the benefit that the patient gets from all these ingredients and the composition is wide ranging. So persons who have heart issues, for example, or obesity, insulin, or the energy production, sometimes you may be feeling tired, lethargic, right? So it has a wide range of functions. And one of the most important functions is that it is an agent that can be used to boost immunity. So the zinc component is very crucial for that immune response. All right, so we have antacid formulation that is very unique and very novel and new to the market. So at the moment, we have first generation antacids, which all they do is just neutralize the acid in the stomach using magnesium and aluminum hydroxide. So that's the first generation. And the second generation now, it doesn't neutralize it as well, but it also has dimethicone or simethicone, which what it does, it helps to control the gas that comes and helps to reduce that flatulence. And on the right, we have a well-hidden example of a second generation antacid. But our product is a third generation, so it's a step up above those. And the name of our product is New Gel, and we also have New Gel O. So why these are more advantageous? The New Gel, it has the neutralizing agents and the flatulent agent, decreasing agent, and we also have alginic acid now, which makes it a third generation antacid. So what the alginic acid does is it creates this foam-like layer when it reacts with the stomach acid. So this layer stays on top of the acid, right? So so for example, if you have a bottle of Pepsi and all right, let me not use Pepsi because with the stomach. So if you have a bottle of liquid soap, for example, and you shake it up and you find that foamy, soapy layer on top, it would be like that in terms of the layer and the distribution. So what the foamy layer, gel layer does, it keeps the acid down in the stomach. So thus it prevents the acid reflux so it prevents the acid from coming back up to the esophagus. And you find that by preventing that, you also prevent the esophagus lining from being damaged, as you find with the acid reflux condition. And it's suitable for children 12 years and up, and for adults. So 10 to 20 milliliters and 4 times per day is the maximum. And for children who are younger, it can be given based on the situation and medical advice. So the new gel now, the difference is that we added alginic acid that makes the third generation, but went a step further now. And this ingredient here, oxetocane, hence the name New Gel O. Sorry about that. So what the oxetocane does is that it is a local anesthetic, and when it is ingested into the stomach, it helps to decrease the pain due to the peptic ulcer. So it would target those pain receptors and helps to decrease that pain that they experience. All right, so I see a question in the chat. How safe is Neurobalin for long-term use? It is safe. It's fairly safe. We haven't had any long-term adverse reactions that are out of the norm, which when you're using the product, you normally have a slight headache or for some persons, a bit of dizziness, especially when they're not used to it. But in terms of long-term use, we haven't seen any prevalent adverse reaction. Is Aminopep subsidized? No, it's not subsidized. The cost is about 2,000, from 1,900 to about 2,200, depending on where you shop for it, which pharmacy. Right, so the New Gel O and the New Gel are our products for the antacid and for the gastritis and the acid reflux condition. And we ask that the New Gel be given to the children and not the New Gel O. And for those who may be pregnant, only use the New Gel as well and not the New Gel O. That's because of the oxetocane. We don't want that interfering with, for example, the smooth muscles in the pregnant ladies. And here's my number. You can always reach out and contact me via WhatsApp or a call, and I'll be willing to answer questions, give information, and provide samples where possible. Another question, can Neurobalin be used instead of Tegretol? All right, so let me, oh yes, and you can continue sending messages in the group, in the chat. I'll be there looking out for it. It depends on what exactly you're using it for. So it depends on the condition that you're using it for. But I know Tegretol is normally used for, like, in the cases of neuropathic pain and epilepsy. So it can be based on the condition, because that's what Neurobalin also targets, the central nervous system, and it helps to reduce that pain. But if it's like treating epilepsy, for example, then not so much. All right, so if there are no more questions, I thank you again for listening, and all the best for the rest of the seminar.
Good afternoon, colleagues. Mrs. Veronica Williams and Mr. Lewis. Ms. Williams, Orion Insurance Broker, continuing support to the Jamaica Animal Nurses Association, and we look forward to an exceptional future with Orion. Mr. Lewis, a very informative presentation. I am certain my colleagues and I have learned something new today. This afternoon, we at the association want to thank you for your timely presentation, and we do hope for your continuous support. Have a good afternoon. Colleagues, friends, we're about to take a break for lunch. We will resume at 1:05 p.m. We look forward to this afternoon presentation as we have Mrs. Carrie Nelson with a presentation, Dr. Sutherland, and Mrs. Roach. So do have a good afternoon. See you at 1:05. That is 30 minutes from now. So see you guys at 1:05 p.m. for continuation of this seminar.
To help a stranger in need is a place If you stand up for those down on their knees and lend a voice to those who cannot speak, if you shine a little light, give sight to the ones who lost their way, there's a place for people like you. I've heard dreams are made of gold, and when you get there, there's a hand to hold. I'll believe when your days down here, there's a place up there for people like you. If you walk around with your heart on your sleeve, and if you try to live a dream you wanna see, if you lay down your life for love so someone could say, there's a place for people like you. I've heard streets are made of gold, and when you get there, there's a hand to hold. I believe there's a place out there for people like you. Streets are made of gold, and when you get there, there's a hand to hold. I believe when your days down here on earth, there's a place up there for people like you. I know you're out there, so keep doing what you do. 'Cause there's a place up there for people like you. If you give a little more than you take, and if you try to fix more than you bring, if you're the kind who takes the time to help a stranger in need, there's a place for people like you. For those down on their knees, and lend a voice to those who cannot speak. If you shine a little light, give sight to the ones who lost their way, there's a place for people If you're walking with your heart on your sleeve, and if you're trying to be the dream you want to see, if you lay down your life for love so someone could see, there's a place for people like you. Streets are made of gold, and when you get there, there's a hand to hold. When your days down, there's a place up there for people like you. Streets are made of gold, and when you get there, there's a hand to hold. When your days down here on there's a place up there for people like you. I know you're out there, so keep doing what you do. 'Cause there's a place up there for people like you. If you stand for those down on their knees, and lend a voice to those who cannot speak. If you shine a little light, give sight to the ones who lost their way. There's a place for people like you. Our dreams are made of gold, and when you get there, there's a hand to hold. I'll believe when you gaze down here, there's a place up there for people like you. If you're walking with your heart on your sleeve, and if you're trying to be the dream you want to see, if you lay down your life for love so someone could see, there's a place for people like you. And when you get there, there's a hand to hold. I believe when your days down here with me, there's a place up there for people like you. Streets are made of gold, and when you get there, there's a hand to hold. I believe when your days down here on there's a place up there for people like you. I know you're out there, so keep doing what you do. like you. Down on the knees. I lend a voice to those who cannot speak. If you shine light to the ones who lost their way, there's a place. Streets are made of gold. And when you get there, there's a hand to hold. I believe when you move down here, there's a place up there for people like around with your heart on your sleeve. And if you try to be the dream you wanna see, if you lay down your life for a love so someone could stay, there's a place for people like you. The streets are made of gold. And when you get there, there's a hand to hold. I believe when your days down, there's a place up there for people like you. The streets are made of gold. There's a hand to hold. When your days down here on earth, there's a place up there for people like you. You're out there, so keep doing what you do. 'Cause there's a place up there for people like you.
Good afternoon, colleagues. Good afternoon, visitors. I would like to thank Frick Israel, our first moderator for this morning session. I would like to also introduce myself for those of you who don't know me. I am Nicola Sampson, second VP to the association, and I am currently employed at University Hospital. I just want to thank those of us who took the time off today to join this seminar. It is very informative. I hope we've learned something new today. And just a reminder, it is Nurses Week, Happy Nurses Week, and Happy Nurses Day on Friday when we get there. Also, a simple kindness goes a long way. We don't know what anybody's going through. It's indeed a challenging time, it's a challenging era for everyone. I'm just asking that we be reminded of these things because kindness doesn't cost anything. It doesn't cost a thing to be kind or nice to somebody else, even when it's not beneficial to us. As we're about to start off this afternoon session, I would like to thank Ms. Williams from Orion. I'd also like to thank Mr. Lewis, who also has from Industrial Life Services. He has 3 giveaways for 3 lucky participants. 3 questions. The first question, I hope everyone has rejoined the platform. I really don't want anybody to miss the opportunity to get any of these gifts. I'm not sure what they are either. The first question is, which ingredient of amino pep is crucial for healthy immune system? The first to reply will be given the token. I will repeat the question. Which ingredient of amino pep is crucial for healthy immune system? Sorry about that, guys, having some technical challenges. And the winner is Sandra Archer. Sandina, correction, Archer. Congratulations, Miss Archer. And the second question. What makes the new gel product 3rd generation antacid? The second question is, what makes the new gel product 3rd generation antacid? Come on, guys. The second question is, what makes the new gel products third generation antacids? So we weren't paying attention in Mr. Lewis's presentation. Come on, guys. It's such a simple question. For those of us who might just be joining the platform, Mr. Lewis has 3 giveaways. And we're at the second question, which is what makes the new gel products third generation antacids? Who is going to be our lucky winner this afternoon? Come on, nurses. A free Nurses Week gift. Come on. And I will repeat the question, what makes the new gel product third generation antacids? Ladies and gentlemen, or gentlemen, rather, nobody can guess that answer to that question? No, Alexis. Almost there, almost got it. Or is it which question you're answering, Alexis? The second question is what makes the new gel products third generation antacids? Crystal loving there. Is that her first response in the group?
Yeah.
Congratulations, Crystal. You are the second winner. And we move on to the third question. What are 5 key practices for a healthy well-being? What are 5 key practices for a healthy well-being? We are at our third and final questions. And the question is, what are 5 key practices for a healthy well-being? Come on, as nurses, we should know this. The chat should be blowing up. Come on, guys. It's only a pity I cannot win. Dixon. Can you look at Dixon's response? And I think the third prize goes to Dixon. I think she has all 5. Dixon, can you retype that chat for me so I can see if you're the lucky winner of the third prize? Muirhead, you're just a tad bit short. I think Dixon got the correct answer. Just waiting for her to reply. Utah, that's a very good one. I would quite agree. So exercise, amino prep, hydration, and sleep and proper nutrition. That's the correct answer. Proper dieting, exercise, hydration, sleep, and amino pep. So congratulations to our lucky winners. I am not sure what the prize is, but I'm sure it will be awesome coming from Mr. Lewis. I want to thank you again, Mr. Lewis. Thanks for your continuous support. As we move into our final segment for this afternoon, she needs no introduction. I will allow Miss Karen Nelson, Senior Public Health Officer, to have the floor. As we give Miss Nelson out of Clarendon some time to take the platform, I just want to thank you guys again for spending the day with Jamaica Enrolled Nurses Association. We really appreciate the sponsors, and we really appreciate the visitors and the presenters. And the persons that flew in from overseas and viewers from overseas, we do thank you for spending the day with us. And it is our Nurses Week. And for the nurses who are late to the platform, I do wish you a happy Nurses Week. I will now hand over to Mrs. Karen Nelson, Senior Public Health Officer from Clarendon Health.
Good afternoon, everyone. Sorry about that. And thank you so much, the team from the Jamaica Enrolled Assistant Nurses Association, for inviting me. And I'm making mention of the president, Mrs. Claudette Clark-Waugh, and the team for inviting me to make this presentation this afternoon. And I just want to also put a plug in to also congratulate the team for celebrating their 50th anniversary this year, and looking at the theme, a very sterling, a very strong and fitting theme for this year, surviving the challenges and celebrating the harvest. I want to just really express my gratitude for the privilege to be able to be in this group this afternoon to share with you at your virtual seminar. Our moderator, Ms. Nicola Sampson, or is it the second vice president? Thank you so much for welcoming me to the platform. And just to say hello to all the persons that are on the platform, those that are here from abroad, those that are here locally, and who are sharing in this week of activities. So happy Nurses Week to the Jamaica Enrolled Assistant Nurses Association and the team of august, profound, stalwart enrolled nurses that we have in our island of Jamaica. Just want to charge you to continue to give of your best and to do your work as you assist in closing the gap in our sustainable development goals and meeting what we know we want to meet the universal health coverage. So at this time, I'm going to try to share the presentation. So let me see if I can share the screen at this time. All right. I'm going to ask permission to close the video because where I'm at, this signal is a little bit weak. Close this segment of it as well. All right. So we're looking at nurses and social media. And as you look at this picture, you're seeing that the most widely used social media at this point in time, and as we speak, is a TikTok. And you see that picture showing that nurses are not left out, you know. Nurses are pretty much on the cutting edge, on the cover page, as they are involved in TikTok. As we look at the definition of social media, it says that social media is an interactive technologies that facilitate the creation and sharing of information, ideas, interest, and other forms of expression through virtual communities and networks. And you and I would have seen how much social media is a very good thing. And on the other hand, it can be a very bad thing. We would have seen with the influx of COVID-19, or when we had COVID-19 coming on stream, that social media at that time was the point of the day, how persons were communicating, help messages, or we were helping using this medium to actually assist the healthcare delivery of most of our, if not all of our patients within that particular time. Now, nurses and social media is a very topical thing nowadays. Everybody is speaking about nurses and social media. And so today we want to look at the impact. What is it? How important is it? And how nurses should really manage themselves as they use these social media or electronic communication gadgets that we have out there. The use of social media and other electronic communication has been expanding exponentially. And I know you would agree with me. And this is because the number of social media outlets, the platforms, and the applications that are available to us pretty much continue to increase. When we look at this poster, we're seeing the multiple different social media platforms that we have. LinkedIn, Foursquare, YouTube, Facebook, Twitter, Tumblr, Flickr, all sorts of Vimeo, LiveJournal, blogs, and so on, that even Instagram, a whole lot that has popped up over the period of years that we have been using to really navigate the sphere and to help us to communicate in some better way, some in a negative way. When we look at individuals use blogs, they use social networking sites, video sites, we use online chat rooms and forums to communicate both personal and sometimes professional with others. Social media, as we know it, is an exciting and valuable tool when we use it. And the big word and the big term that must be crucially adhered to there is wisely. Social media possesses tremendous potential for strengthening professional relationships. And it also, on the other one, provides valuable information that we can use for cues to action. Since its launch in 2004, says that Facebook, yes?
Just a second. Persons are saying they're not seeing your slide.
They're not seeing the
They're
slide?
not moving.
I'm going to close it and try and share again. All right? Let us.
Much.
Welcome. Is it down now? Is it down? You're not seeing the slides any at all now, right? Are you seeing it now? Stop share. Start again. Are you seeing that slide now? Even the front slide? Are you seeing the slide from the beginning? Someone could just let me know.
Yes, we are. Sorry about that. Yes, we are
seeing it now.
Yes, we are.
All right, so let me see if I can just go back a little bit. So we spoke about the definition of, you're seeing that slide now with the nurses that are now on TikTok?
No, we're not.
I'm not sure what is happening. I'm gonna take it out of slideshow, you see? And just proceed in the normal.
Okay, thanks much.
And let us see if we can move it along like that. All right, so if you can see that now, are you seeing that now? Are you seeing the nurses on TikTok now?
Yes, we are.
All right, so I won't put it in slideshow. There seems to be a little issue, so I'll try to navigate it from this end, all right? So this is what I was saying, that the most widely used social media is the TikTok, right? And you see there, the nurses are saying that we are now on TikTok, a very exciting moment for nurses at this time. When we look at the definition, social media are interactive technologies that facilitate the creation and sharing of information, ideas, interests, and other forms of expression through virtual communities and networks. So the next thing we're looking on is nurses and social media in a broad way. So the use of social media and other electronic communication is expanding exponentially. And I was saying that I know you would agree with me, because the number of social medias that we're using, the outlets, the platforms, and the applications available to us continue to increase. And so we would have seen this with the multiple ones I'm showing now that is coming up on the screen, the YouTube, the Twitter, the Facebook, right? You have LiveJournal, Flickr, Instagram, and we could go on and on. So nurses are using blogs, social networking sites, video sites, online chat rooms, and forums to communicate both personally and professionally with others. And they're also seeing the social media as an exciting and valuable tool when we use it wisely. And so I was reiterating that the importance, or the main word that we should ponder there on, is using it wisely. Social media also possesses tremendous potential for strengthening professional relationships and also for providing valuable information. Since the launch of it in 2004, Facebook has grown to become a global presence. We're looking at least 2.96 billion monthly active users as of the fourth quarter of the year 2022. Instagram users have also rose to a mass of 1.28 billion, and over 4 billion persons are today using Twitter. Social media is also seen as a part of all our lives. It especially, even we would have seen when COVID came in, it was a great, huge part of our lives as we were using this sort of platform to communicate regularly with our persons when we would not be able to see them physically. It is entertaining for one, and it is very informative. It allows us to connect with individuals and also brands. And it is an access to share timely news. And I know you will all agree with that in a nutshell sums up what the social media is for us. Social media use can improve provider to provider communication as well, and coordination of patient care, facilitating the quick transfer of information. And that is a very positive way of how we would have seen the nurses using the social media to improve the quality of care of the clients and the patients that we serve. Social media helps to increase the visibility of the nursing profession also as an entity, and the critical role of that nurses are playing in our healthcare system and communities worldwide. So indeed, we are saying that we are embracing this social media and the technology that it comes with, because yes, it is contributing to us providing quality care if used in a very professional way. A major negative effect of social media on nursing practice is the potential to cause distractions and interruptions. And you can agree with me, because if a nurse is attending to a client and has the phone at their ears, we're losing that medium at this point in time, and they have the phone at their ears, they can have a lot of issues happening by just doing that. It breaks the concentration. It provides for that distraction that they're talking about, an interruption, and then they would lead to errors into nursing care. So there are a lot of errors that can come out of just doing that. There have been several studies implicating technology as a contributing factor in causing distractions and interruptions among our nurses. And we have seen a lot of these. There are times when persons have to have legal implications when they are not doing according to the protocols and the guidelines. And they would have erred with these social medias or these gadgets that we have to use. And sometimes it becomes a problem in the delivery of care. When we talk about the distractions that may occur because of the sound that may come, or a vibration that a message might come in on the phone and so on. And then additionally, there may also be some mental distractions. Just by knowing that the message is there, you can't wait to hear who wants to get in touch with you, or so on. And so you are not paying that crucial attention to your client. And so this is how these limitations or these issues may arise. When using social media, nurses must foremost protect the patient's right to privacy and confidentiality, and consider the potential effects of their communications on the patient, the employers, the profession at large, and even for the nurse themselves. And you and I can attest to that, who is on the platform here, that indeed the work that we do, we have to safeguard the employer who employs us. Most of all, we have to safeguard the patient. And then our profession, because of the entire nurse and practice, nurse and profession, nurse and employer, nurse and patient, nurse and relatives or friends, is very important. So we have to look at that in a very important way. The inappropriate use of social media also by nurses is causing a concern among educators, the employers, the regulators, and the nursing organizations are beginning to develop some guidelines as it relates to how nurses should really be operating in the sphere of using these social media and the platforms, whether the gadgets at the particular time around the clients or the patients and so on. Employer policies typically do not address the use of social media to discuss workplace issues outside of the work or home or the computers or personally owned phones and other handheld electronic devices. It is in the context that the nurse may face potentially serious consequences for the inappropriate use of social media. So most importantly, we must know that we have a responsibility. And so it is important that these policies and guidelines that our institutions, our association are on it to be able to safeguard us by putting in some practices that can be able to assist us in how we move appropriately to use these gadgets in a safe and professional way. When we look at sharing of information, we know that sharing health information of patients, regardless of whether it is in a good or bad light, would be seen as a breach of confidentiality and privacy. And we all know that even in our training and even before we were employed, based on the staff orders, based on the different guidelines and principles in our institution, would have known that these key areas are important and they must be adhered to. When we look at sharing of photographs, it's similar to sharing information. Sharing of photographs of patients is also generally not allowed, even if the patient is not named. And even when I remember when I was coming into the profession, and I know you would have been also faced with that based on the guidelines, that we weren't really allowed to take pictures. But now at that time, we didn't have these smartphones that could take pictures and so on so readily. So people are now indulging even more. But we as nurses do have a responsibility to our institution and to ourselves. So we will be able to make sure that we are not compromising the patient's welfare. Posting unprofessional behavior is also important. Many nurses believe that information shared privately on their personal page is not subjected to professional scrutiny. And I just want to say that we need to know that these platforms are owned by someone. And remember that the networking that they are shared, the networking system is a shared one. And so sometimes when we think that our information is just for us, we have a rude awakening. Others are also accessing our information and actually seeing what we are doing on these systems. However, evidence and unprofessional behavior can negatively impact one professional career, and that is a given. Particularly charged comments such as those about alcohol, sex, drugs, or race could lead to an unprofessional behavior charges. And I'm going to speak to that in a more deeper way. Another concern arising from social misuse in its effect on team-based patient care. We know that if we are doing things, it's not just us that it would be affected, but whatever we do in an inappropriate way affects the team and it affects the patient care that we give to our patients. Online comments by nurses regarding co-workers, even if posted from home during non-work hours, may constitute lateral violence. And when I speak of lateral violence, I'm talking about things that include disruptive behaviors of intimidation and bullying via the internet, and what we would see happening and termed as cyberbullying. And such activity is a cause of concern for current and future employers, those that are regulating us as well, because it negatively affects team-based care, as I was saying before, thus creating a patient safety ramifications. And we as enrolled assistant nurses, we definitely don't want to be seen in that area, contributing to that negative impact of using these social media platforms. Nurses must not only be mindful of what they post. So it's not what you put up alone. A 2018 study from a career builder found that 70% of our employers use social media to screen for job applicants. And 43% of the employers monitor the employees' social media networks. And even if you're trying to get a visa or so for whatever entity it is, being US or Canadian or so on, you know that one of the things that they particularly do, these agencies or these embassies do, is to check on your social media post. And if you have been found to be disruptive or found to be posting things that are not in keeping with certain guidelines and principles, they're not certainly want to have you in their country. And so they'll certainly use that as a medium to block you or not give you that free entrance into that particular country and so on. I just want to point out that we are living in an online. We're living online at this time. And COVID-19 and other public health emergencies would have drove us into that. So, but we have yet to fully recognize the implications of doing so. And one of those implications is that our tracks through the digital sand are eternal. And that's simply what I was saying before. That's some of the things that you put up, you cannot remove. And those will stay with us on that platform, on that network for eternity. There are a few cases that would have looked on of persons utilizing social media and how negatively it would have impacted certain aspects of their life. One such instance is a nursing student shared 2 photos of a newborn who was recuperating in a unit that she was providing some care. She was excited and proud of the progress of the baby under the care. However, the nursing school was subsequently banned from the hospital and blacklisted from other hospitals with neonatal units until it could provide their policy on social media, because for one, the student nurse would have done what is totally contrary to the guidelines and the principles of that institution by sharing that photo, even though she would have been excited about it and was looking on a different end, looking on how the baby was progressing and so on. She did not know that sharing it in such a media would have brought some publicity to the institution that she was currently working at. And so it would have not been a positive thing to have done in the first place. And it would have been breach of the policies for the institution. There was also a nurse working in a hospice care, and one of her patients maintained a hospital-sponsored communication page that they were using to keep friends and families updated on her particular battle with cancer. One day, the patient herself posted something about her depression. So the nurse wanted to, show that she was giving the patient some support and so on. So she posted something back and said that I know that the last week has been difficult. Hopefully the new happy pill will help along with the increased dose of morphine. I will see you on Wednesday. Remember now, this posting that she was doing would not have been viewed by herself alone. This is being viewed by others. And so the site was automatically listed and the user's name with each comment. The next day, the nurse was shopping at a local grocery store when a friend stopped her to ask about the patient's condition. I saw your posts, they would have said yesterday. I didn't even know that you were taking care of X and Y. I hope that the new medication helps with her pain. So you see now, the patient's condition is not confidential anymore. It is now brought out into a now public light. There was also a licensed practical nurse for more than 20 years. Now we're talking about an experienced person working on the ground who used his personal cell phone to take photos of a resident in a group home where he was working. He had received permission from the patient's brother as he was unable to give consent due to her mental and physical condition. The evening, he saw a former employee of the group home, and while catching up, he asked about some of the long-staying patients. This nurse now showed him the photo and discussed her condition with him. The administration of the group home later learned of this action that would have been executed, and you know what happened there. The person was terminated of his employment because there was a breach of what? Confidentiality. So it is prudent that as nurses, we are careful what kind of information we are sharing and how best we are keeping the patient's information as very private and confidential as we can, as we should, not even can, as we should and as we must. In 2021, there had to be some representation for a nurse who took pictures of her facility that was flooding out. She didn't just stop there. She started posting these pictures and she tagged a public figure. And you know what would have happened after that. It would not have been now, things that should have been dealt with locally now would have now reached in the public spaces. So we must understand that nurses can get the best out of social media while safeguarding themselves, the profession, and their patients. So it is important as we navigate the field of nurses and social media, we must be aware of our audience. We must maintain, most importantly, our professionalism. We must know our social media policies, secure our social media profiles, share credible information only, and engage with our respectful content. I've gone on some pages of healthcare workers, nurses alike, and even the profile pictures that are posted up for these persons are left to be desired. Now, if it is a professional page that we are putting up, we must be aware that we should actually execute accordingly. And remember that the nurse is a professional, dignified officer that is not only seen at the bedside or seen within the workspaces, wherever you are, whether in the public spaces, wherever you transcend across the globe, you are still a nurse. And so the respect that persons would give you based on your conduct, if you reduce or water down your conduct outside of the profession, you will have issues and the profession would not be seen to be respected. So we're asking that even as you look at yourself as a nurse, just make sure that you are looking at the professional leg that spans all aspects of your lives. The impact of social media on nursing practice hasn't been widely studied based on what we would have seen on the ground yet, and it isn't well understood. There are potential benefits of social media use, and we would have seen that. But the possibility does exist that social media use by nurses can have unintended negative consequences on the quality and the safety of patient care due to primarily distractions and interruptions that we would have previously mentioned before. As social media becomes even more intertwined with the daily professional lives of nurses, it's crucial and imperative that the impact on nursing be studied to ensure the patient care is enhanced and not compromised. So we will seek to continue to do additional studies as we move along the continuum of caring for patients in this kind of a time or atmosphere of social media. So therefore, we are all cautioned to think before we click. If people do not know you personally, and if they cannot see you as you type, what you post online can take out the context if you are not careful in the way your message is delivered. So package your messages in a professional and profound way. I just want to say at this time, this ends the presentation. And thank you very much for listening. I just want to say to us that as nurses, we have a role to play. We have a responsibility to carry out the mandate of our institution, the mandate of the Ministry of Health and Wellness. We also have a duty to our clients, both personally and professionally. And so as we continue to give of ourselves, to give of quality care to our clients and our patients, I ask that we just uphold the standards and ensure that we as nurses know how to professionally navigate these social media platforms. Thank you so much for listening, and over to you, moderator.
Wow. Timely, very informative session. The Jamaica Enrolled Nurses Association would like to extend a hearty thank you, Mrs. Nelson, for the very informative presentation on nurses and social media. And we will not compromise the patient's welfare moving forward. I hope no members of the Jamaica Enrolled Association has compromised the patient welfare. Yes, we are indeed living in a new era, but we need to be reminded as healthcare professionals the implication and the impact social media can have if used inappropriately. We're not saying, oh, we're not going to use social media, but my grandmother used to say, there's a time and a place for everything under the sun. So as we go forward in this new era, we need to remember the codes of ethics. Simply, the code.
That's it.
We learn these things
Code of ethics.
We learn these things in school, and if we stick to what we were taught, we would not be here. We shouldn't have any issue, because how dare you share patient personal information by whatever means? When if it is that I'm discussing with an outside nurse about a patient, I say patient X, or a patient that's on my ward, have a condition that I cannot relate to. Do you have any experience? That's how we're supposed to ask. Nobody needs to know what the name of the patient. How dare you take up a phone and say, oh, we're venting. Yes, we use social media to vent, but we can vent without giving away patient's information. And we need to remember the code at all times. We're governed under a particular code. And if we stick to that code of ethics, we cannot go wrong. Thank you, Mrs. Nelson. It was a pleasure. As I said, it's very informative and it's a very timely manner, because as you say, we're living in an era. Do have a blessed afternoon.
Before I go,
I would like to give a member on the platform a token. I have a question. The first person to get this question right will be given something nice, something all of us desire. So the question is, when was Facebook first launched, and how many users are currently there using the platform today? It was on Mrs. Nelson's slide, so if you were paying keen attention, guys, easy 1, 2, 3. Let's see who our lucky winner is. The question is, when was Facebook launched and how many users are currently on the platform? No, Miss Morrison, come on, it's one question. It's one question, it's not two separate questions. One question. So I will repeat for the, come on, nobody uses social media to figure this out. You should be paying attention. So therefore, it was right there. It was the first thing that caught my attention when she started her slide. When was Facebook launched and how many users are currently using the platform? Loving dear, you're close, but you're far. Good effort, guys, but still we haven't gotten the right answer so far. Still waiting. Ruthan, no man. Come on, Ruthan. We weren't paying attention. Let me repeat the question. When was Facebook first launched and how many users are currently on the platform? 4.5 billion users, 8 million. Come on, guys. We're guessing. Shawnette, you're almost there. Loving dear, just a tad bit more. Manina, still not right. You're getting, guys keep getting half of the question right. You need to complete the entire question. So I'm going to repeat. When was Facebook first launched and how many users are currently on the platform? All right, so we'll take the answers in the chat. I'm still waiting on the correct answer. Loving dear, you're close, but you're not there. All right, as we move along.
Lady Sampson,
Lady Sampson, like to present to us.
Lady Sampson.
Speaker this
Hello.
afternoon.
She's not hearing me. Lady Sampson.
Sashali Roach,
not hearing
assistant dietitian at Spanish Stone Hospital. She attended University of Technology where she did her bachelor in dietetics and nutrition and currently working in the capacity for over a year. Let us give her a warm welcome at this time. Mrs. Sashali Roach is our next presenter for this segment.
Yes, good afternoon. Thank you for that great introduction. I'd like to thank the Jamaica Enrolled Nurse Association for inviting me to present on this topic today of nephrotic syndrome and the dietary management of it. So let's get straight into it. Let me share the screen. Okay, so the dietary management of nephrotic syndrome. All right, so what is nephrotic syndrome? Nephrotic syndrome is a kidney disorder that causes your body to pass too much protein in your urine. It is usually caused by damage to the clusters of small blood vessels in your kidneys that filter waste and excess water from your blood, which causes the urinary loss of albumin and other plasma proteins of similar size. This can occur due to progressive glomerulonephritis and diabetes mellitus, among other conditions. And the condition causes swelling, particularly in your lower extremities, your feet and your ankles, and increases the risk of other health problems. All right, so signs and symptoms of nephrotic syndrome are weight gain, proteinuria, hypoalbuminemia, hyperlipidemia, edema, chest pain, hyperkalemia, weakness. Patients with the syndrome usually have some form of glomerulonephritis with renal failure not too far behind. So a background of the syndrome is that the syndrome is not necessarily a diagnosis of a particular renal disease, but it can occur in a number of conditions, including glomerulonephritis, as I said before, diabetes mellitus, and amyloidosis. Patients who are not edematous or hypoalbuminemic are said to have nephrotic range proteinuria. So nephrotic range proteinuria is where in a 24-hour urine collection, protein levels are higher than 3.5 grams. The mechanism of proteinuria is complex as it occurs due to structural damage of the glomerular basement membrane, which leads to an increase in the size and number of its pores, allowing passage of more and larger molecules, including plasma proteins, into the urine. And this may lead to a reduced plasma albumin level and a consequent decreased colloid osmotic pressure. Also, a reduced colloid osmotic pressure in turn causes fluid to be lost from the intravascular space into the surrounding tissues, thus lowering blood volume, cardiac output, and blood pressure. So a reduced plasma oncotic pressure activates plasma renin and aldosterone, leading to salt and water retention, which causes edema in the lower extremities. All right, a background of the syndrome now is that it's an increase in hepatic secretion of lipoproteins, and coagulation factors also occurs in the nephrotic syndrome. This leads to the clinical abnormalities such as hyperlipidemia and hypercoagulability. The increased loss of protein can result directly or indirectly in excessive losses or several ions and trace elements from the system. Micronutrients such as vitamin D, iron, and zinc are normally bound to proteins in plasma, are lost in the urine, making it possible for depletion to occur when proteinuria is excessive. So objectives of management of nephrotic syndrome. All right, so in managing nephrotic syndrome, we want to ensure efficient utilization of fed proteins spared by use of adequate calories. And we want to prevent muscle catabolism. And if protein losses are severe, albumin infusion may be needed, but this is rare. We want to reduce edema. We want to control sodium intake with otherwise uncontrolled hypertension. We want to monitor hypocholesterolemia and elevated triglyceride levels, monitor the patient for potassium deficits with certain diuretics, replace any other nutrients, especially those that are at risk, such as calcium and vitamin D. We want to prevent or control renal failure as well. Dietary management centers on the problem of salt and water retention, protein depletion, hyperlipidemia, and loss of carrier proteins for vitamins and minerals. So a very high protein diet will alter glomerular filtration rates, but so we want to limit protein to decrease hyperfiltration. A diet that is low in protein, however, is much more recommended because it provides adequate energy and can maintain a positive nitrogen balance in the syndrome. We also want to ensure that the patient receives adequate calories, and this is calculated based on individual needs of each patient. We want to ensure that the patient is meeting the dietary reference intake for vitamins and minerals, and if needed, supplementation can be added. The reasons for altering a nephrotic syndrome patient's diet are to help control the symptoms of the syndrome, prevent long-term complications, replace nutrients lost in urine, optimize nutritional status, and reduce the risk of progression of renal disease. So the dietary recommendations for nephrotic syndrome, in terms of energy, we want to calculate the energy of the patient, the recommended amount of energy needed by the patient is calculated according to each individual patient's needs. So the energy intake needs to be adequate for correct utilization of protein. High daily intakes around 50 to 60 kilocalories per kg are essential. Complex carbohydrates should be the primary source of energy intake. And since appetite is usually poor in these patients, much encouragement and support is needed. So the food must be as appetizing as possible, visually appetizing and tasty in a form that is most easily tolerated. So the diet, in order for the patient to receive adequate amount of energy, the diet should provide 35 kilocalories per kg per body weight daily, as I said before. All right, for carbohydrates now. Carbohydrates, as I said, it should be the primary source of energy. So carbohydrates should provide sufficient calories for energy needs. And this will also reduce the catabolism of protein and prevent starvation ketosis. Carbohydrate intake should be high to spare protein for breakdown on proteins. Replacement of the prolonged nitrogen deficit is a fundamental and immediate need. The treatment of nephrotic syndrome does not include a high protein diet, as this would not replenish plasma protein levels and could cause further renal damage. Some studies suggest that a low and very low protein diet with essential amino acid supplementation reduces proteinuria and improves protein nutrition. Daily protein allowances will vary according to the need of the patient, from 1 gram per kilogram per day to larger amounts in extreme cases. High biological value proteins, which are proteins that contain all essential amino acids such as meat, poultry, milk, fish, eggs, they should contribute to at least 50% of protein intake. If the blood urine nitrogen is elevated and oliguria is present, dietary protein must be restricted. So oliguria now is when there's an abnormally small amount of urine being passed by the patient. So in this case, we have to adjust protein intake. All right, so how much protein is recommended for a nephrotic syndrome patient? There has always been a lot of debate over the amount of protein recommended for nephrotic syndrome patients. In the early 20th century, high protein diets were recommended for nephrotic patients, but there is no general consensus that these diets are not appropriate, as high protein diets, which were used in an attempt to maintain serum albumin concentration. However, a number of studies have shown that increasing the protein intake merely increases the losses in the urine, and that maintaining a good energy intake is more important for maintaining a positive nitrogen balance. With the high protein diet now, the high protein diet further damages the filtration barrier of the glomerular capillary, resulting in protein losses. And this may increase the rate of renal failure and may increase the serum phosphate levels as well. So some studies suggest that the composition of protein in the diet may be as important as its absolute nitrogen content. And it was found that in patients with nephrotic syndrome who were fed a vegetarian soy diet had decreased urinary protein excretion. It is recommended, as I said before, that patients with nephrotic syndrome should consume 0.8 to 1 gram protein per kilogram per body weight per day for a variety of protein, from a variety of protein sources, sorry. All right, so for fats now, in the case of elevated levels of cholesterol and triglycerides, limited total fat and cholesterol intake, decreased intake of concentrated sugars and alcohol is recommended for the patient. Hypercholesterolemia and hypertriglyceridemia results from increased lipid synthesis and decreased lipid catabolism. This disturbance in lipid metabolism increases the risk of cardiovascular disease, stroke, and progressive renal failure. So a combination of statin therapy and a modified diet lowers serum lipid levels. Fish oil supplementation may be also beneficial for patients who have immunoglobulin A nephropathy, which is caused by the deposition of immunoglobulin A in the kidneys. Elevations in serum lipid concentrations are a feature of the nephrotic syndrome as well. So increased serum concentrations of total cholesterol, low density lipoprotein cholesterol, and very low density lipoprotein cholesterol are the most frequent abnormalities reported. These abnormalities have been shown to reverse once the patient achieves remission. Although the degree of atherosclerotic risk as a consequence of hyperlipidemia is uncertain, patients are advised to modify their fat intake by using polyunsaturated and monounsaturated fats and by reducing their intake of saturated fats. In regards to sodium now, we have to combat massive edema. So sodium levels in the diet must be significantly reduced. So usually a 500 milligram sodium diet is sufficient. If the patient has edema, sodium will be further restricted sodium intake should be restricted to 2 to 3 grams. The restriction of sodium varies with the degree of oliguria. So if the renal function is impaired, the sodium will be restricted to 500 to 1,000 milligrams per day. And as recovery occurs, sodium intake may be increased. Edema formation is one of the most distressing symptoms of the nephrotic syndrome for most patients, as the patients can gain as much as 30 kilograms of weight, and while they have the appearance of being well nourished, they may not actually be. They may also complain of feeling fat or feeling bloated, which can leave them at risk of reducing their kilocalorie intake to achieve a more desirable weight. So edema in itself can also lead to a reduced appetite and anorexia, and this can further reduce a patient's nutritional intake, leaving them at risk of further malnutrition. Strict sodium restriction plays a central role in the management of edema-associated nephrotic syndrome in the past. However, the use of more powerful diuretics now makes this unnecessary in the majority of patients, and a no added salt diet is now advised. So most of our dietary salt intake is derived from salt already added to manufactured food, and not adding salt to a habitual diet will only reduce intake by 15%. It is also worth noting that a no added salt diet can also help to reduce thirst, as patients are advised to limit their fluid intake. Potassium restriction is not necessary, as diuretics decrease potassium levels in the blood. But with severe oliguria, renal clearance of potassium is impaired and potassium intoxication may occur requiring dialysis. So thus, potassium intake is monitored according to the progression of the disease. Iron and vitamin supplements may be helpful as well. So our micronutrients know which are our vitamins and our minerals. So these are important. The importance of these losses to the clinical manifestations of the nephrotic syndrome is not well established. For this reason, the routine administration of a supplement is not recommended. It is suggested that if the patient adheres to a moderate protein diet, no added salt, and low saturated fat diet, the extent of the proteinuria and edema formation should be reduced and loss of these important micronutrients are minimized. Provide adequate amount of vitamin D and calcium as tolerated, and replace zinc, vitamin C, and folacin and other nutrients to monitor iron according to laboratory values. All right, so fluid restrictions now. So fluids are restricted in keeping with the ability of the kidney to excrete urine. If restriction is not indicated, fluids may be consumed as desired. Fluid restriction may also be necessary if edema is refractory to diuretic therapy. Strategies for reducing fluid intake. All right, so in tips to reduce fluid intake, we can use smaller glasses or cups to drink from. We keep track of how much fluid is being taken in each day. Avoid salty foods, as salty foods increase thirst. Instead of having liquids, you can have frozen pieces of fruit to help quench thirst. And instead of swallowing, we can rinse them out with cold water, so to help quench the thirst without taking in the excess fluids. So, all right, for nephrotic syndrome now, the main aim of nutritional management is to replace the protein loss by having an adequate intake of proteins. However, high intake of protein must be avoided to prevent any tubular damage to the kidneys caused by filtering of the excess proteins. Sodium and fat intake in the diet should be low, and foods that can be eaten in liberal amounts in patients with nephrotic syndrome are cow's milk, skimmed milk, and yogurt, wheat, cereals, sprouts, pulses, and legumes, eggs, fish, chicken, lean meat, etc., vegetables and fruits, soups, sauces, juices, as long as they are low in sodium content, moderate to low intake of vegetable oils, butter, and mayonnaise. Foods to be avoided now are foods that are excess of proteins, because a very high protein diet, as I said, can cause tubular damage to the kidneys, as the kidneys will have to filter more of the proteins. But moderate intake of protein, which is about 1 gram per kilogram body weight, is mandatory to compensate for the protein loss in the urine. Foods that are high in fats. High amounts of fats should be avoided, as the cholesterol and triglyceride levels tend to be high in patients with nephrotic syndrome. The diet must be high in calories as to conserve proteins, yet low in fats. So excess of oily food and saturated fats should be avoided. Foods that are excess of sodium. Sodium in the diet should be restricted so as to prevent fluid accumulation and edema. The foods that are high in sodium content and thereby should be avoided are salted popcorns, biscuits, snacks, chips, etc., commercial salad dressings and sauces, salted cashew nuts, pistachio, walnuts, peanuts, salted or canned meats, foods containing baking soda, soy sauce, smoked or tinned fish in brine, salted seasonings, and that's is the presentation. So let me conclude by stating that dietary management plays an important role in the management of nephrotic syndrome. So if dietary management is not followed, the condition can and will worsen, resulting in further complications, leading to extensive damage to the kidneys. Hence, restricted protein, high carbohydrates, low sodium with moderate fats and restricted fluids is recommended for nephrotic syndrome patients. Vitamin supplements, especially vitamin C, has to be supplemented along with a modified diet, and this will ensure better health and longer life for the patients. So thank you for having me again. That's my presentation.
Lovely present. Mrs. Roach, I want to thank you for spending the time to inform us about, remind us about nephrotic syndrome. I'm certain a lot of my colleagues have learned something new this afternoon. So from the Annual Nurses Association, we'd like to extend a hearty thank you for spending your afternoon with us. And we do hope you continue to assist wherever is needed. Thanks very much for that lovely, very informative presentation. At this time, I would like to ask a question to see who was paying attention, because I was quite concerned that all these wonderful presentation came after lunch. And you know, us Jamaicans, once we eat our belly full, you know, we're ready to sleep. So let's see who was paying attention. The question for this afternoon, and who knows, you might be given a token. What are some of the things patients with nephrotic syndrome should avoid? 1, 2, or 3. Just you can give me 2. List 2 things patients with nephrotic syndrome should avoid. Come on, guys. I'm sure. One more, Ruthan. Good job, good job. I see you, love, in there, representing for University Hospital. Good job. Small, I see you too. All right, thanks, guys. I will tell you at the end who might be going home with something this afternoon. Mrs. Roach, I want to thank you again for that presentation. At this time, we would like to introduce our next speaker, Dr. Navita Sutherland. She's a consultant gynecologist, and she's here to talk to us about cervical cancer. Right? I know we know, but you know, we know about the condition, but a little reminder goes a far way. All right, so just bear with us as I'm about to let Miss Sutherland speak to you with regards to cervical cancer. Do enjoy the rest of the presentation. You know, as with technology, we do seem to have some glitches as we try to navigate our way through the system. do bear with me. I'm going to ask you for 2 minutes to try and see if we can allow Miss Sutherland to Dr. Sutherland to come on screen. Just give us a few minutes, guys. While we wait, is there any question for Mrs. Roach? Anybody would like to ask any questions? The floor is open for questions and answers. There are no questions? Nobody would like to ask Mrs. Roach any question? Good afternoon, colleagues. Let me say thank you to our presenters and thank you to you, our wonderful audience, to the persons who are streaming from overseas. We have some of our enrolled nurses who are streaming from overseas. Thank you for being here with us, and to all the nurses right across Jamaica and internationally, I want to extend to you a wonderful, peaceful, happy, and joyous Nurses Week and Nurses Day. Go out, treat yourself to something special. Let your hair down, smile a while, forget the troubles, and have fun.
And all the mothers who are on the platform, let me also use this opportunity too to wish you a wonderful Mother's Day. And may the Lord continue to bless you as you continue to nurture both children biologically and those you have adopted. And if there's any teacher on the platform, you see, the month of May, you know, have a lot of wonderful things happening in May. It's Child Month, it's Nurses Day, and we could say Nurses Month also. It's Mother's Day, call it Mother's Month. And we have Teacher's Day, call it Teacher's Day. So to all the teachers on the platform, happy, blessed, and prosperous Teacher's Day to you. And to all our viewers, I pray God blessing upon you, and may you live to see many, many happy, prosperous lives. And may you continue to do what you love and love what you do. And as someone said, nursing is a calling. And I believe those who love nursing are truly called. And as I said to someone when I was asked what kind of work I do, I said, I'm an angel. He asked me, what do I mean? I said, I watch over you while you sleep. So as nurses, you know, we work on night shift, so we watch over our patients while they sleep. So we are angelic, we are nurturers, we should be very high in our artificial intelligence. We should be caring, loving, and kind. And may God bless you, as I said, and have a wonderful, happy Nurses Day. And from us here at the Jamaica Enrolled Nurses Association, we thank you for being a part of our national seminar. A big thank you to our presenters. We have one more presentation to come, Dr. Sutherland, and we are waiting on her to join, but she'll be a little bit late. So I'm just trying to engage you guys while we are waiting. And just to say, the Jamaica Enrolled Nurses Association, we are located at 130 to 132 East Street, Kingston. And to all the nurses out there who are not a member of your professional organization or your professional body, so whether you're a registered nurse, a registered midwife, or an enrolled assistant nurse, I use this opportunity to implore you and to ask you, please become a member of your professional body. As the saying goes, seek a friend before you need one. Sometimes the things that we worry about are the things that stresses us most. And I know some of us are worried about the dues that we have to pay, but we should let that be the bottom line of our worries, and see the opportunity to become a part, seize the opportunity to become a part of your professional body. Because as it says, together we can achieve much. And we are looking into a new era of nursing where we will stand united, whether enrolled assistant nurse, registered midwife, we're all caregivers, and unity is strength. And I think that when we stand united, then we cannot fall divided. And as the ICN has the saying that said, one voice to lead. And as nurses, we need to have one voice. We don't need to have 10 different voices. We need to have one voice, and that one voice will lead. So let us let us become a part of our professional body, I implore you. And just to say, for those enrolled nurses who are on the platform, remember our health fair, and our health fair is open. That our health fair will be open to all the general public, and our health fair will be on June 21, that's Wednesday, June 21, at Macon Health Center. That's our national health fair. And also we'll have our social on the third Wednesday in July, and we have our annual conference and award ceremony, and that's in October. And I'm imploring, if these events are open to others, you can make contact with the representative, each enrolled representative, and of course, they will give you the information as it relates to our conference. Our conference this year will be held at Iberia Star, and it is going to be our 50th annual conference to mark our 50th celebration. So we'll be having our banquet on November 1, and our banquet will be at Iberia Star. Cost will be $15,000 per ticket for our banquet, and I am imploring all enrolled nurses to be there and also to come to our conference.
Good afternoon, colleagues. Good afternoon, visitors again. Just a reminder, I see a few questions popping up in the chat with regards to CMEs. At the end of the link, the Zoom link, to log on, there is a registration form. In order to get your CMEs, you have to complete that form. It is simple. Just click the tip of the link. It says register. You type in the necessary information, and we will submit the CMEs to the email given to us in that registration form. And as our president stated earlier, our upcoming health fair is in June. We are gearing and we are ready for change as our theme states. All right. So be reminded of our health fair in June. It's June 21 and it is in Maypen, Farringdon. So load up the bus, the car, the taxi, the vans, and let us meet you all in Maypen on the 21st of June, 2023 for our first, but not our last, health fair. It's the beginning of new things. As we go through our week, I would like to wish you all a happy Nurses Week. Happy Nurses Day when we get there on Friday. It's International Nurses Day. For the teachers on the platform, or for us nurses who have teachers in our midst, do wish them a happy Teachers Day on behalf of the Jamaica Enrolled Nurses Association. You're doing an exceptional job. And mind you, I don't know if I was a teacher how I'd manage, because boy, my head tough. So I can only imagine most of our kids out there, and with computer and technology taking over, it makes it even harder to reach these students. So you're doing a marvelous job. Continue to keep up the good effort, the good work, and I wish you nothing but the best. I hope the government will increase all our wages, because we all deserve our pay. Just going to read a quote for us nurses as we celebrate Nurses Week. As nurses, we have the opportunity to heal the mind, soul, heart, body of our patients. They may forget our names, but they will never forget how you made them feel. Maya Angelou. It is so true. Sometimes, I don't know for anybody, but sometimes I'm walking in the supermarket, I am in the market, and somebody might say, Nursey, do you remember me? I don't remember them, but they remember me, or they remember what I did for them. So I know sometimes as nurses or as healthcare workers, we get lost in the system. We are so frustrated as to how management treats us, what is happening in our personal lives, but never for a second doubt that you've impacted somebody's life, because they expect nothing but the best from us whenever we go to the bedsides. And we must be reminded that these patients are ill. Sometimes they might appear ungrateful because, you know, they're going through their struggles, they're sick, and I think our society, especially in Jamaica, they think that as healthcare workers, you know, we're robots. Because sometimes I think they don't realize that we bleed too, we get sick too, we have personal, emotional, all these ailments that we go through like anybody else, but we are expected, you hear the word, we are expected to smile and be happy regardless, because that is what they want from us. So as we go through our week, remember, a simple kindness goes a long way. And sometimes we might not benefit today for the good that we do. And mind you, we can never be paid enough for the job we do. Believe you me, nursing is a calling. It's either you love it or you hate it. It is a calling. It's either you love it or you hate it, because I don't think the government could pay us for what we do. I remember a couple of years ago when I came into nursing, I was talking to this police lady, and she was saying, oh, our pay is more because we risk our lives. And I sat there and I listened. I was like, wow, so we don't risk our lives. What about when COVID-19 come in? I'm just saying this is new, but you know, what happened when COVID-19 come in or came about? I remember seeing my colleagues crying because there's so many deaths around us. And I remember days when I cry, when I sit on my way home, crying from work because I'm like, is this my last week? Will this be my last day? I remember being on the ward. And boy, every time I think about this, and I'm grateful for God for his mercies. I remember one day I'm on the COVID unit, and while they're on the COVID unit, I was given, you know, as annual nurses, we get the worst patients. It's sad. We get the most work and we are least appreciated. I remember being on the unit and I had this man. He had COVID-19 and he had a large dressing. And this man was coughing. He was coughing excessively. Mind you, I never mind nursing the patient as I'm there to do a job. And it's one thing, if you know me, you know I do my job well. And the patient was coughing excessively, and I went to work the day and they were like, oh, Samson, it's your turn to go down on the COVID. It's your turn to nurse patient X. I was like, my dear. And I remember just sitting at the nurse's station and gearing up, because believe you me, it's a mental battle to go into the COVID department or go into the COVID unit. It is a mental fight for those of us who worked COVID units. I know you know what I'm talking about. It's a fight. And I remember talking myself up because I'm like, yes, we can breathe. And yes, and anyway, I was sitting there gearing up mentally, physically. You know, I love music. So I was listening to music, trying to boost the spirit to go down there because I'm like, oh Jesus. Done my PPEs and brand new, I got a brand new shield, you know, because sister come and say, yes, me get shield phone and thing. I'm gonna put on, well, nice, I'm gonna take pictures and my go on with myself because I say, yes, I feel nice, I'm well covered, I'm well protected. But you see, before I end this story, guys, we have to be covered under the blood of Jesus, especially in this field, because some days I think if it's not for the grace of God, I would not be here. Rest assured, if I'm not Jesus, it's nobody else. As I say, it was a brand new shield, brand spanking new. And as you can see, more glasses. So put on my glasses because I can't see. I'm not gonna hide that. Put on my glasses. I don't know if I know God, I don't know who. Put on my glasses, put my shield over it, feel uncomfortable because it feel like something I pressed down on your face and you have man, I know. But you know, but when I had on my mask, my fitted mask, I felt as though I was suffocating. And you know, when you got COVID, you spend sometimes, depending on what you have to do for those patients, you spend hours down there. And that patient I had to bathe in that morning. And I put on my mask and I put on, I go down there. And as I said, I took pictures before going down there. So I feel nice, well energized and well ready for the task given to me. Down there, I'm down there, the patient X. Finish baby and say, yes, I'm going to do the dressing now. Bathe him. And I do things I don't know for anybody else, but I have stages in which I do whatever it is that my task. So I bathed him, I gave him his medication, I did the vital. So the last thing for me to do was do the dressing and get out. The last thing. As I said, if it's not for the grace of God, I don't know who it is. But do everything for this patient and doing the dressing. Head down in a sweater, pour, and if anybody ever work on a COVID unit and you have on the gowns, because I had to change my uniform, so change, and we had on the gowns that we would provide. I had on not the gowns, the scrub, and then we had the gowns over it, and everything. So, my heart started to drip. I'm down there, I'm at the dressing, and the sweat was pouring down my mask. My mask was fogging up. The amount of sweat, I couldn't see sweat going down in my eyes, and I was just there. I said, Jesus, 5 more minutes. Boy, 5 more minutes, sweetheart. Wow. That 5 minutes, that afternoon was the longest 5 minutes of my life. You know what happened? When I was at the last leg of the dressing, the shield burst, drop a ground, boom. And I'm like, it's brand new. What is happening? It is brand new. I mean, start fretting now, because like my eyes. And I'm telling you, the patient was coughing, and all you are telling him to keep on the mask. He said, nurse, I can't breathe. I said, sir, put on your mask. And said, nurse, you don't understand. I said, all right, my cough excessively, I understand. He's already having respiratory illness. Some say, all right, I'm going to be lenient because I'm not going to be hard because I know how I feel when I have all these masks. And this patient was coughing over my face with the shield broken. And because of how you put on your mask and your shield and everything, that part of the mask had lifted. I had to literally hold my breath. I didn't run. I didn't run from the patient because I could have came out of the unit, duff and re-enter. And I was like, I'm not going to go through all of this again. I'm going to literally hold my breath to complete that mind's dressing. Literally, because when I ran out of that unit that afternoon, my supervisor asked me if my alright because I literally ran because I was about to pass out. So let me tell you, what we do is no joke. So I know no matter how they go, but some persons out there might say, oh, you guys, it's not worth it because you only spend 2 years in school, and we're given the hardest, the worst patients 99.9% of the time. And that day when I came out of that area, that unit, that afternoon, I cried. You know why I cried? I thought about going home to my family and say, I have COVID-19. I thought about where am I going to sleep that night because there's no preparation. I don't remember. I don't know if I had it, but the patient was directly over my head coughing. And if I remember the day when I spoke to that police officer and she said, oh, we get more paid. We don't go to school. We don't have degrees. We don't have diplomas. But we get more paid because we risk our life. And I'm like, am I not risking my life? They risk their lives. Their lives. We risk ours and our family. Because many times we fail to understand that's not just COVID-19 that we face. We have other bacteria that we come in contact with each and every day. And yes, we might be sitting in a taxi and be exposed to these bacteria. But there's so many things as nurses or as healthcare workers we face in the hospital. It is funny. I'm sure if we're to line up some nurses right now and swab them skin, them nose, them eyes, them ears, the amount of bacteria that we will find on them, we will wonder how we live. We will wonder some of these things will probably have multi-drug resistance bacteria growing all over our body. And it's sad. One thing is sad is that the country failed to realize and recognize that they need nurses. And if they treat us a little bit better, wow. I'm just saying, wow. It's sad that our nurses are migrating, but I understand. Because how do you feel working so hard? Sometimes I was saying to my colleague the other on the unit that I hate when I see colleagues living bad on the ward because I spend more time on this unit than I spend at home. I only sleep at my house. I don't know about anybody else in this group. I only sleep at my house and I occasionally visit because when I do get my day off, when I do get that day off, I have so many things to do that I have to schedule time to spend with my loved one. And it's sad. It is quite sad. And we're not appreciated. We don't feel valued. We don't feel respected enough in our own country. And these are some of the reasons why the nurses migrate and management fail to understand. I'm sharing something else and I might get in trouble for this one, but I'm just going to share it regardless. The other day, the unit was very hectic and I was coming down with flu-like symptoms. Everybody knows there's a terrible flu going around. But if you know me, and if you've ever worked with me, you know, even when I say I'm sick, I give 150%. And when I come to work and I say I'm tired, and then you see me giving less than 150%, you know I've had it up to here. And the unit was very hectic. And as usual, as I said, we are usually given the worst set of patients to deal with. And the following day, I went home. I take the staff bus home. The staff was to leave at 8:30. I left the ward at 5 minutes to 9. I don't drive. 5 minutes to 9. All right. Have a 7 o'clock shift in the morning. The staff bus picks me up at 4:45 every morning. And if you're not on time, they're not waiting. So 5 minutes to 9, I was still at University Hospital, not knowing how I was going to go home because I didn't have a ride downstairs waiting on me. I had to call a taxi. Pay $3,500 to go home. Reach home. By the time I waited on the taxi and I got home, it was minutes to 11. All right, minutes to 11. By the time I showered, unwind, because depending on the kind of days that we have, sometimes we can't just brush and go to sleep. I don't know about you. I have to evaluate myself at the end of the day. Did I do enough? What could I have done differently? So it takes me a minute or two. Sometimes it takes me an hour to go to sleep because I have to think about everything that I've done throughout the day and to analyze what I can do different. That's how I survive. And that is how I ensure that I give nothing but my best. So, get on to 11. I don't remember exactly what time I got there, but it was 12. It wasn't after 12, it was 12. Set my alarm. Alarm go off. I feel like I never sleep. Someone said 5 more minutes. You know, I overslept. So the morning I thought about asking my partner to drop me at work, but I was so mentally exhausted that day. I get up and it's like I'm confused. And I looked at the staffing, I looked at everything and I was like, hold up. I think you're gonna do a good enough job if you go work today, because at that time of the morning I wanted to sleep. I went from my bedroom to the living room and I fell asleep for 5 minutes. I went in the bathroom and I sat on the toilet and I fell asleep. I was exhausted. I called and I ahead of time, they had enough time. It was more than 2 hours, or a little bit over the 2 hours, or a little bit under the 2 hours. Either way, there was enough time. And I called and I said, I don't think I'll be able to come into work today. I am not well. And you see, our colleagues need to remember, illness is not just physically. We deal with what we do for a living. Your mind must be free. If you are mentally exhausted, it can cause you patience. And I think sometimes management fails to remember this and fails to realize this. I wasn't mentally prepared for work that morning, so I told them I was not coming. And you know, the following day, I got called into a meeting to say I abandoned my job. And I don't understand, you know, there are some days I really don't understand. I think management don't remember what it feel like to work, to be a factory worker, because that's what we do. We're factory workers. They get the praise, we do the work. And I got called into a meeting, and I was so hurt. When I got called into the meeting, I was so hurt because I'm like, you didn't see what time I clocked out last night, but you see that I didn't come to work the following day because I'm exhausted. And exhaustion is not a reason. Ladies, just say this to say that physical illness is not the only illness. Sometimes we push ourselves to the limit and we fail to realize that medication error can be caused by mental exhaustion. It can be caused, one simple miscalculation can cause your patient life. And that is why when people look at me and say, oh, you don't risk your life, I just smile because you wouldn't know half of the story. Because some days, it just takes your brain for now work for 2 seconds. And remember, as nurses, even though we're sometimes not considered nurses, as nurses, we have to sharp up here, because if we're not sharp, man, tell you, because sometimes these physicians make some order, and if your brain not working, sister and brother, your brain not work. Remember, I know them not going to say, they're not going to say, let me speak standard English. They're not going to say that the doctor made an error. They're going to say, where is your judgment? Where is your knowledge to know that this doesn't make any sense? And that is why I say, if you are tired, take your vacation, take your time off. You are entitled. Don't let anybody cause you to feel as though you're not entitled to those days. You are entitled to those days. Take your days. Don't feel sad. I know sometimes, because I do it too, I'm guilty of this. I go to work because, you know, I have a set of co-worker and I know say if I go, and you know, it won't be so hectic, and at least work together and we'll help each other. I don't know who I'm talking to, but you need to think about yourself. You need to think about your family. They're depending on you. They're relying on you to come home safe. And one mistake. See? One mistake, that 2 seconds, that extra day where you could have taken a rest, give your body, it's not all about money. A couple of years ago, my mindset was on a different journey. Currently, I'm living, not telling anybody to follow me. Don't follow me, but I'm saying live in the present, because we planned many a times, we plan for a future, and I was talking to somebody the other day, and this is why I'm smiling. We plan for a future, and we do goals after goals after goals. So we set a goal for this year, accomplish that goal. Then we set another goal, accomplish that goal. Only to realize that you spend no time living. You don't do anything for fun. You haven't gone anywhere. You haven't done anything that you like doing. Take the time for yourself, ladies and gentlemen. It's not just for nurses, also for the teachers. Yes, we have to be ambitious, and government not paying us enough now. We need to do the overtime, and we need to do all these things to continue to make our bread and to provide for our family. But at the end of the day, we live once. And are you truly living? If every single time you set a goal, you move towards the next goal, not appreciating where you are and where you're coming from. Guys, I think I have exhausted this. I don't think we realize how hard our job is, and we do need the time to recuperate and to just unwind. These days, most of my days when I take my day off, I'm so sorry for my family members because they suffer. I can't tell you they suffer because these days when I get that, if I have to work 6 days a week and I get that one day, I spend half the day in bed doing something I want to do. It's not selfish. I know moms probably on the floor and they're like, oh, but the babies have to eat. The babies. Yes, and that is why raising a family is not only for the mothers. It's not all about money. They have aunties, they have uncles, they have grandma, they have grandpa, they have daddies. I love them. Sometimes we are overbearing and we think that, oh, hubby now go get the job right because me know how to do it. How will you know how to do it if you don't allow them the opportunity to do it for you? Take the time for yourself, ladies, gentlemen as well. Take the time. Remember to help your partner. Remember, while working, remember we're a team. Remember we're a team. We can't do this, nothing at all in this world by ourselves. Not a single thing. And change your mindset. Don't allow one conversation with one person to destroy an entire 24 hours. Time wasted can never return. You can never lose that which is gone. So sometimes we spend the time being angry about one single thing, or we forget to cook the little food for you to eat, or somebody forget to do something, and you're so angered that you spend the entire day being angry that you miss out. One thing I've learned over the past couple of years, the past year and a half, is that I spend an entire day being angry about something that I have no control over, and life does not stop. I think we fail to realize that we spend the time being angry about something, and we're angry from 8 o'clock in the morning and 8 p.m. in the night, we're still angry. But being angry doesn't change anything. I'm not saying you should not express your emotion. I'm just saying don't allow anger to consume you. Don't allow hate to consume you. I think we're consumed by these things. Be angry for a minute, be angry for 5 minutes, be angry for an hour, but don't let that anger go on for hours and days and weeks. It's quite unnecessary because life not stop. And that we feel for realize that today's the 10th. Yes, today is the 10th of May 2023. And if I'm angry this morning, I'm gonna wake up tomorrow, I'm gonna feel like, oh, I'm not about angry anymore. You think I can get back the 24 hours I had today? No, honey. No, sweetheart. It's already gone. And it was already wasted being angry. And anger doesn't change anything. Our perception. I'm not saying don't be angered. I'm not saying don't get sad. Don't let it consume you. I think I've exhausted everything. I don't think I have anything else in me to tell you yet. So let me check if our final speaker for this afternoon has joined the platform. Well, she is asking for a few more minutes. So anybody have any question about our upcoming calendar of events? Because I'm done talking. I leave the floor open for if anybody wants to ask any question, seek any clarity on anything. Why it look like someone borrow me to death? So yes, our upcoming banquet. So it's Spruce Up Your Goal event. So for though I don't know if Madam President has stated the cost, it's $15,000 for banquet additionally. You can come to banquet, you don't. I would like for you guys to come to conference because it is our 50th celebration. It's our 50th anniversary. Come on, man. It's a grand event. We only get to 50 one time, you know? Not 2 times, 1 time. So it is open to the public. So you can come that one night for just the banquet. You can bring your spouse, you can bring your friends, you can bring your family members. It is open to everybody. You can invite your church sisters, you can invite your co-workers. You know, it's called Spruce Up Your Goal. So any goal and anything you want to listen, it's a fashion show. It's our 50th celebration, so it should be grand. All right, I'm going to hand you over back to Madam President. Just give us a sec.
All right, good afternoon again, colleagues. And has the question was posed that a person would need some more insights. And further to what our first vice president has said, our second vice president, thank you, has said, keep mixing up. Our banquets this year, very first award banquet that we'll be having, it will be a part of our conference. However, it will be on the Wednesday evening, the 1st of November. So our conference will run from the 30th of October to the 1st of November. However, if you want to book and go down on the Sunday, you can, and we're encouraging persons to book with the association. So you can get further details on our bookings. We start our bookings already. We have our package, so you can contact the association regarding our package, and you can also contact myself. My number is 876-414-8280. 8280. And for the banquet, we'll be also having a Nurse of the Year, an enrolled Nurse of the Year. An award will be given to an enrolled Nurse of the Year. And we have the criteria of the nurse will be chosen. The criteria will be sent out to all the directors of nursing services to choose. And the criteria will speak for itself. Members of the executive are not eligible for entry.
Not fair.
I know. And my VP say it's not fair, but I know nothing in life is really fair. So that's what make up life. So all the executive members, they are not eligible to enter. And one of the things with the award for the enrolled nurse of the year, you have to be an active member of the association for over 2 years. So even if you're an enrolled nurse for 5 years or 10 years or 30 years, and matron recommend you, if you are not a member of the association for over 2 years, and the word active speaks for itself. So if you're not an active member of the association, then you would not be qualified for that award. And also the banquets will fall under, as I said, our conference. So it will be at Iberia Star. The cost is only a meager $15,000 per person. And children can come, but once your child is over 7 years old, then it attracts an adult. It's not our say, it's the hotel's say. For conference, we have double bookings. Persons can book double, they can book triple, or they can book 4 to a room. And you can contact me regarding the rate, and also for our banquet. If you're coming for banquet and if you come down for the banquet for the Wednesday and you want to stay overnight, then you know you would have to pay for overnight stay. So I would advise you then to book with the association. We start our booking already. We start booking from as early as March. So you can still book. You can do your weekend, or you can do your transaction online. So once you get in touch with me or our office, then we can give you the information. And also the executive member, we have an executive member in all our parish, in all the hospitals, health centers, health departments. We have executive members out there where you can get in touch with them. And our rates for the conference, they are very affordable, for want of a better word. So once you contact us, we will give you these rates, and then we can tell you how to do your booking online through our banking system. You can do your online booking. So you don't have to worry about going to the bank to pay the money joining the line. We have our account and we have our online system at the bank where you can transfer the money, even lying down in your bed from the comfort of your home. It doesn't matter what you're doing, you can still make your online transaction. And suffice to say, let me encourage all our nurses, not just enrolled nurses. You see, it is very, very important to be very active in your professional body, because you might go to do other business transactions and they ask you, are you a member of NAJ or are you a member of GINA? And it is very sad sometimes to see people only when they want the benefits that are offered through the association, that is when they try to become a member. And before I said, seek a friend before you need one. Don't wait until you want a branch to do study, then you're going to find your association, your particular association, and become a part of it. No, don't wait until that. Don't wait until you are caught in an incident on the job and you need representation at the nursing council. Then you're going to be seeking down and finding your rep, whether it be an NAJ rep or a GINA rep, for you to sign up. No, I implore you guys, be a part of your professional body and take part in the activities, because I'm sure that the director of nursing services in all of the health facilities across the island, they do give the nurses the opportunity to participate in the activities of their professional body, be it church service, social, conference, health fairs, what you name it, as long as they are provided with the information before time, I'm sure they will, because they have been doing it. And I want to say thank you to all the directors of nursing services across the island who has been successfully participating in the activities of the Jamaica Enrolled Nurses Association. Matron Brown Smith in Maypen Hospital, Matron Sadie Williams, Mandeville Regional Hospital, Matron at Black River Hospital, Matron at KPH Hospital, and just to name a few, these are some of the matrons that have been supporting. Matron Robinson, Spanish Town Hospital, all these directors of nursing service, they have been so supportive with the enrolled nurses. And guys, please, I implore you, if you put your situations to the matrons, they will give you the time. Because somebody's asking, is there an ID when you join Gina? What we're going to do presently, we don't give, the executive members will be provided with ID, but for the general members of the Jamaica Enrolled Nurses Association, you will be given a membership card, and we're going to try to get your pictures. So what we're moving forward, as our theme was last year, moving forward with a vision, what we're going to do is try to get the membership cards, and with the membership cards, a picture also will be provided. And who knows, in the future, God willing, you might very well end up with an ID. But for now, we are going to be issuing all our members with their membership card. So at least you can have that as proof that you are a member of the association. So guys, as I was saying, please participate in the, please guys, participate in the activities of your professional body, and also just to encourage us to remember to be appropriately attire according to the nursing and midwifery policy from the Ministry of Health. I don't know about you guys, but I love my uniform. I love my uniform. And when I have on my uniform, I think I'm the best thing around. I don't care about anybody else. When I have on my uniform, nobody nicer than me. Nobody sweeter than me. I am all that and more when I'm in my uniform, and especially when I am representing my association and I'm fully decked in my uniform and my blazer. Nobody like me. So guys, I'm imploring you. And as I remember one of our presenters at our conference told us one year, and she said, you are your own brand and you display your own brand. And just remember, for people at work, they might not have the opportunity of seeing you when you are out of your uniform to say, oh, but she can carry herself good. Let us bear in mind that we spend more time in our uniform than anything else. And first impression last. And just let us remember, when we are leaving our homes every day as we go out, it doesn't matter if we're working at the same institution for 40 years or 20 years or 5 years. Remember, there must be somebody who is going to see you for the very first time. Not everybody will see you every day, because not everybody will be able to be seen by all of your employees or co-workers, your colleagues. Sometimes you must see somebody, you're seeing somebody for the first time. And it is the same thing that will happen. Somebody is going to see you for the first time, and the first impression does last. So guys, let us step out. When we step out in the morning, let us step out with dignity and with pride. And I know I'm speaking to all nurses here on the platform. So let us step out with dignity and with pride. You know, God could have made it that He could have put it in the heart or in the mind of those who make decisions for us. He could have put it that we wear black. But guess what? He put it in their mind, He put it in their thinking for us to wear white. And I've never seen an angel, but from pictures that I see, I realize that all the pictures of angels, they are always dressed in white. So it is saying something to us that as nurses, we are to be Christ-like. So when we attire ourselves, we are to attire ourselves as representatives of Christ, from the very head to the toe. Even if at times, because of our situations, our minds can be a little bit shattered. And when I say that, I mean we could be having death in the family, we could be struggling with our own emotions, but it doesn't have to show on our hair, clothes, and shoes. It does not have to. It does not have to. We can, no matter what we're going through as nurses, we can present ourselves in the best way. We can be the best. When you look in the mirror, you're supposed to look in the mirror and smile and say, wow, I am wonderfully and beautifully created by God. There's a question in the chat about social. Okay, so for social this year, we'll be going to Somerset Falls in Portland. And the various hospitals will be putting on their trip to come to Somerset Falls in Portland. As when the politicians, they're having their campaign, they say all roads lead to the National Stadium or the National Arena. So on the third Wednesday of July, all roads lead to Somerset Falls in Portland. And the cost to enter is $1,000 for adults. And there we will be having our fundraising event. So we'll have on sale we'll have things on sale for fundraising event. Also, as part of our 50th anniversary, we have our anniversary t-shirts. We have our t-shirts on sale, our beautiful memorabilia t-shirts. And I'm asking, it's for anyone. As long as you have the $2,500, you can get one of our t-shirts to buy. So you can place your orders with our executive members out there, and then they will surely collect the money and get sent. You will get your t-shirts. And also, just to let you know, that a part of our activities week this week is to visit the retirees or the elderly. Somebody's saying, is there a Gina 50 pin? Not yet. If you come to conference, then you might be. I'm not telling you all the stories. So I'm not telling you all the things. We have to leave some things for the imagination of the mind. But just to say that a part of our activities week is to visit the retirees. If you don't have a retired nurse in your area, you can also visit a senior citizen. Just bring a little thing to give them, sit down, have a little talk with them, see how they're doing. If you're not in close proximity to a senior citizen or a retired nurse, it doesn't have to be an enrolled nurse. It can be any retired nurse, as a matter of fact, let me not just limit it to nurse, any retired healthcare professional. You can visit with them, talk with them, bring a little something to give them, and let them know that they are still appreciated. If you don't have any retired healthcare worker where you are, then visit a little shut-in. Go talk to that person, pray, give them a little something, and let them know that they are still valuable members of society and they are still loved. All right, guys. And just to say, I really, really am grateful for this opportunity to be representing all the enrolled nurses out there across the island. And I really love you guys and appreciate you guys. And I wish for you guys nothing but the best in life. And as our theme says, surviving the challenges, embracing or celebrating the harvest. And at this time, our presenter is here, and without further ado, let me welcome to this platform Dr. Sutherland. She's a consultant gynecologist, and she will be talking to you this evening on cervical cancer, and I implore you to pay keen attention. Listen, if there's any male on the platform, listen so you can pass on the information to the females in your lives. Thank you. I appreciate. Thank you, Nurse Williams Bailey. And guys, I appreciate you. Dr. Sutherland.
Hi, good evening or good afternoon,
Good
everyone.
afternoon. Welcome.
All right, you can hear me great. Let me apologize for the late start. And I will just get right to it. And feel free to ask. I'm not quite sure how you want me to do it. Nurse Wall, would you like persons to leave their questions and comments until after the presentation? Or you want it to be a dynamic presentation? You can just let me know. I'm gonna try and share the screen. All right, so I was asked by Nurse Wall to do an overview of cervical cancer. So I'm just going to share my screen and I will get right to it. Presenter view. All right, are you
Sorry about that. Good afternoon. Nurse Simpson here. You can do it however you want. That's fine by us. You decide how you want to proceed.
Oh, okay, no problem. We'll work it out as we go along. Sometimes I find when we leave the questions until afterwards, the questions get lost along the way, but I'm fine with whatever. But I'll start, as I know you guys have been waiting for quite a little while now. So for today's presentation, I really wanted to focus on the cervical cancer burden in Jamaica, give an overview of the cause of cervical cancer, how we manage the disease, how we come to the diagnosis, and importantly, since I'm presenting to the nurses, the role or the potential role of nurses in the management of a patient with cervical cancer. Now, in Jamaica, there are approximately 1.5 million women who are greater than 15 years old, specifically in the 15 to 44-year-old bracket, which represents the reproductive age group of women in our society. And it is estimated that of that number, 400 are diagnosed yearly with cervical cancer. And this is data from 2021. And in the grand scheme of things, 400 is not much out of 1.5 million, but you are thinking about a diagnosis of potentially terminally ill disease in 400 women who are in the prime of their reproductive age group usually, and who are usually significant contributors to the workforce in Jamaica. And then when you look further, 63%, more than half of those females who are diagnosed with cervical cancer end up dying. And this is significant because cervical cancer is a preventable disease. So we are talking 250 deaths that could have potentially been prevented and 400 diagnoses that could have potentially been prevented. And currently, this is the third most frequent cancer among women in Jamaica and the second most frequent cancer among women who are in the reproductive age group. And then this number, of course, would significantly increase if we extended the age bracket to up to 70 years old, because we also have a significant amount of women being diagnosed in their 50s, 60s, and those are patients who usually present with advanced disease. Now, what causes cervical cancer. Now, as a medical group, I'm sure I would hope that we have all heard about the HPV virus. Give me 1 second, please. I'm getting a call from the hospital. 1 second. All right, sorry about that. Right, so the HPV virus is rightly described, the human papilloma virus is the predominant cause of cervical cancer. And it is a sexually transmitted infection which results in cancer by entering cells, the cervical cells, through tiny bruises in the cervix, which we can all visualize how easy that can happen during sexual intercourse, with subsequent replication of the virus, which, if left uncleared from the immune system, leads to further replication and abnormal changes in the cell, which subsequently lead to cervical cancer. And I must point out, in the last portion of this slide, you can see that it takes a period of up to 30 years sometimes to lead to cervical cancer, which again is very important in the management of cervical cancer, because it can't be stressed enough that cervical cancer is preventable, especially when we have a 10 to 30 years span to intervene before frank cervical cancer develops. Now, there are at least 120 types of the HPV virus, but the ones that we would be most concerned about are types 16 and 18. And these cause in excess of 75% of cervical cancer, and significantly as well, more than 50% of vaginal and vulvar cancer. So that accounts for greater than 90% of genital tract cancer with regards to the vagina, vulva, and the cervix. I want you to also take note that at the top of this slide, it says HPV is a necessary cause of cervical cancer. This is important because once females begin having sexual intercourse, it is almost inevitable to contract the HPV virus because the virus is so prevalent. So it is not just contracting the virus that will lead to cervical cancer, but generally there are other factors that, in combination or in addition to the infection with the HPV virus, will increase one's risk of developing cervical cancer. These include an immunocompromised state, such as HIV, patients who are on immune-altering drugs, for example, chemotherapy, as well as other high-risk factors, such as multiple partners that will lead to multiple infection with the HPV virus, low socioeconomic status, which generally includes poor health performing habits, as well as smoking, and other sexually transmitted infections, because those increase the risk of damage to the cervical mucosa, which increases the risk of HPV infection and then prolonged infection. I should also mention, even though they don't lead to cancer, that the HPV viruses type 6 and 11 lead to anogenital warts in 90% of cases. Let's see. And again, this is just showing the distribution of the different types of HPV viruses that exist. And this will become important in the options we have for managing cervical cancer and preventing cervical cancer. So as you see here, HPV 16 accounts for more than 50% of cases, and HPV 18 accounts for approximately 20%. In combination, in excess of 70% of cervical cancer cases are due to HPV 16 and 18. Further, the HPV virus not only leads to cervical cancer, vaginal cancer, but it also leads to oropharyngeal cancer in 72% of cases. Most of the anal cancers, penile cancers, vulvar cancers are due to the HPV virus. And this is a virus that exists in, or that infects more than 90% of sexually active individuals. And because of this, you can understand why there is a significant burden from the HPV infection and the HPV infection leading to cervical cancer. And this is a burden that we really don't need to bear, because again, whilst the infection is not preventable, progression to cervical cancer is something that can easily be picked up and prevented. And how can we as professionals, medical professionals, reduce this risk, this burden, this incidence of cervical cancer? And I'm just going to touch on that briefly, and then get into some more specifics in terms of management. So management of cervical cancer really begins with prevention. And this cannot be stressed enough. I'm sure we've all heard the term prevention is better than cure, and it could never be more applicable in this case. And prevention is something that it is so easy, but I'm not quite sure why it isn't so a very successful feat that has been undertaken in Jamaica. And it is a combination of cultural habits, as well as lack of resources. So the first step to preventing cervical cancer is vaccination. And I'm sure are all familiar with the concept of vaccination, which is really to identify persons who do not have any symptoms or evidence of infection with a disease, and administer some sort of intervention to prevent subsequent infection or diagnosis with a particular condition. And these persons that are identified are generally persons who are at high risk. And in fact, there have been at least 3 different options or 3 different vaccine types available for cervical cancer. The next step to vaccination is the pap smear. And this is for all patients, even if vaccination has been done, because vaccination, while it's efficacious, it does not prevent 100% of cancer prevention. So the pap smear is still necessary in terms of screening. And again, screening is where we identify those persons who are not infected, and we pick up the early lesions that will warrant or necessitate intervention to reduce progression to cancer. And then finally, we have the HPV test, which may seem a little novel in Jamaica, but it actually has been around for years and has been proven to be an important part of the management of patients who have cervical cancer. And then I will discuss that a little further. Now, to the HPV vaccine. The HPV vaccine prevents 90% of HPV cancers, and we have discussed, or I had mentioned previously, the different types of HPV cancers that exist. It can prevent at least 6 other types of cancers. And here again, if we have 5 people in a room, at least 4 of them will contract the HPV virus in their lives. So the linchpin of the HPV vaccine is that we want to administer this vaccine before these 4 persons here contract the virus, because by the time they would have contracted the virus, they would have already had the antibodies on board to prevent infection and subsequently prevent development of cervical cancer. Now, who does the HPV vaccine protect? Now, at this point in time, coverage is given to the 9 most common HPV strains that can lead to cancer. Patients are also given coverage for oropharyngeal and genital cancer. 90% of cervical cancers are prevented from the HPV vaccine, as well as 90% of the genital warts are protected by the HPV vaccine. Now, I should mention that, and I think I previously did, that the HPV virus, despite being infected with it, generally clears within 1 to 2 years. But the problem is when you have prolonged infection, and the HPV vaccine not only prevents infection from the HPV virus, but it also prevents prolonged infection with the virus and subsequent development of cervical cancer. Now, what are the options for the HPV vaccine and when can they be administered? The first vaccine that we were exposed to is a Cervarix, and the Cervarix is actually a bivalent vaccine covering only 2 types, the HPV 16 and 18. And this is because most of the cancers that develop from the HPV infection are due to 16 and 18. At this moment, Cervarix is no longer on the market. So if you see it available, we need to check the expiration date to make sure that it is something that may be administered to persons. So it's no longer marketed in the US. And as far as I know, it's not offered or no longer offered in Jamaica. When they had started the attempt to vaccinate the school-aged children, it was Cervarix that was administered, but it's no longer on the market. So we have had to move on to Gardasil. And there are 2 types of Gardasil. There's Gardasil, the quadrivalent vaccine, which covers 611, which accounts for 90% of the anogenital warts, and 16 and 18, again, which accounts for more than 70% of cervical cancer. Gardasil is what is actually offered in the public system free of charge to any patient who qualifies. Now, who qualifies for the Gardasil vaccine? And the Gardasil vaccine may be obtained, as far as I know, at the Comprehensive Health Center that's on Slipen Road, as well as I was told you may get it at the Augustown Health Center. I'm not quite sure about that last one, but definitely you can get it at Comprehensive Health Center. And I think it's also administered at Victoria Jubilee Hospital on the vaccination or at the vaccination unit. Now, the dosing schedule for the quadrivalent is dose 1 is given at 0 months, dose 2 is given at month 2, and 6 months later, dose 3 is given. So it's a 3-dose schedule. More widely administered now or currently is the Gardasil 9, and this is administered, or this is available in the private sector. It can be obtained at Health Brands, which is on Hagley Park Road, and they said it at a cost of almost $18,200. And it provides protection against 9 different strains of HPV. So you can understand that coverage or cervical cancer prevention is significantly better compared to the Cervarix and the Gardasil. The coverage is for HPV 6 and 11, 16, 18, 31, 33, 45, 52, 58, and the L1 protein. which means that compared to the other vaccines, which give about a 60–70% coverage, the protection that is afforded by Gardasil 9 has sometimes been quoted to be anywhere in the region between 80 to 85, sometimes up to 90% prevention of cervical cancer from administering the vaccine. Now, what is the schedule for the Gardasil 9? It's ideally recommended for males and females between the age of as early as 9 years old. And 9 years old is recommended because we want to be able to administer the vaccine before the onset of sexual activity and to give sufficient time to develop immunity by the time the sexual activity begins. So if it is administered between 9 and 14 years, basically, only a 2-dose series is given, which of course means less costs, less risk of potential side effects, even though the side effect profile is very low. And the second dose is given 6 to 12 months after the first dose. If the first dose is administered after 15 months, then a 3-dose series is undertaken again at 0, 2, and 6 months. The vaccine is marketed up to age 45 years old, but it is not ideal to administer between 27 to 45, but some protection is better than none because, again, most of the diagnoses of cervical cancer is made between the ages of 15, or a significant amount are made between the ages of 15 and 45. And you see here, it says a shared clinical decision, because once you have been infected with one strain of the virus, protection is not offered by administration of the vaccine. And after 45 years, the vaccine is not recommended again because the risk-benefit ratio is going to be significantly higher because it's very likely that most of those patients would have already been exposed to a significant variety of the HPV virus. And so not much benefit would be obtained from administration of the vaccine. All right, so the second step in terms of prevention is cervical cancer screening, which we are all familiar with. There are 2 options for screening, and these are international guidelines, and these options are also offered here in Jamaica. We recommend administration of the pap smear starting at age 21. And the pap smear, regardless of onset of sexual disease, of sexual intercourse. So if you have a patient who you are seeing who is 18, 19, who has just had her baby and coming to postnatal clinic for checkup, or coming to the hospital for any sort of abnormal discharge, cervical infection, it is not recommended that these patients be administered a pap smear. We wait until 21 years old because we want to reduce the amount of false and negatives that are associated with the pap smear, because the pap smear is not a foolproof screening test. And the risk of progression to cervical cancer with infection less than 21 years old is very low. So we recommend screening to commence at the age of 21, and we recommend every 3 years, provided that their pap smear results are normal. Thereafter, they can continue every 3 years up to age 64, or if you add the HPV test, which is done in the same way that the pap smear is done, except the HPV test is suspended in a particular solution and sent to the lab for testing. If you add the HPV test, the cervical screening is every 5 years, provided both are negative. And the importance of the HPV test is to identify the presence of high-risk cervical HPV viruses, such as 16 and 18. Those are the 2 that are tested for. And if those are present, the risk of progression to cervical cancer, especially if those viruses are not cleared, are significantly high. Now, if you have a negative HPV test, in addition to a normal pap smear, your risk of developing cervical cancer or abnormal cells within the next 5 years is significantly low. And so we have the latitude to expand the testing for another 5 years in this higher risk age group. And in terms of screening, just a note, once you are over 65 years old, no screening is required, provided that the patient has had a regular screening in the past 10 years and no abnormal precancerous lesions on the cervix in the last 20 years. If that is the case in terms of abnormal pap smears within the last 20 years, you continue your screening until you reach a 20-year mark, or of course until the patient demises or there's no role for further screening. But let us say that we missed the mark, we didn't manage to administer the vaccine to the cervical cancer screening, which is a reality in our setting in most times. What are the main or what are the red flags, I guess, to look out for in terms of identifying a patient who may have a diagnosis with cervical cancer? And the most common thing is vaginal bleeding. Unfortunately, though, I must say that most persons who have precancerous cells are asymptomatic, or precancerous or early cancer cells are asymptomatic, meaning those patients are not going to be picked up unless they do a pap smear. By the time the patient presents to you with vaginal bleeding, it is likely that they have very early advanced stages of cervical cancer, or unfortunately in our stage, advanced stages, and there's not much hope for doing minimal intervention in terms of curing. They may also present with a watery and foul discharge. Again, by the time they get to that stage, they generally have a necrotic lesion on the cervix, which suggests that they have advanced disease. Pain in the pelvic region, again, suggests nerve invasion, and weight loss suggests systemic changes due to the presence of the cancerous cells or the cervix. And these patients, you're looking at very invasive interventions to not necessarily cure, but to reduce the bulk of the cancer cells, and then either move on to radiotherapy or chemotherapy. How do we make the diagnosis? Let me make it clear that a pap smear cannot make the diagnosis of cervical cancer. The pap smear is a screening test. Once you get an abnormal pap smear, even if it says cancer on the pap smear, the next step is to proceed with colposcopy and biopsy. Even if you see an abnormal lesion on the cervix, the diagnosis of cervical cancer is not made until you have taken a biopsy of the cervix and submitted it for histological evaluation, and you get a report confirming cervical cancer. In addition to the biopsy and in the cervical curettage, which is basically a D&C of the cervix, because you can have abnormal cervical cells just in the lining of the cervical canal and not on the external portion of the cervix, or a cone biopsy, which just takes a bigger portion of the cervix, are submitted for histological evaluation and confirmation of the presence of cancer cells. Once you have made the diagnosis histologically, we move on to imaging, and this may include an X-ray, a CT, MRI. These are all dependent on what other symptoms the patient may have, but at baseline, an MRI must be done because the final staging of the patient is a combination of histology and imaging. And The MRI is useful because the cervical cancer spreads by expanding to nearby tissues. So that will tell the extent of spread of the cancer cells, as well as whether or not there are any regional lymph nodes involved. And a CT after chest and abdomen will let us know if, though unlikely, there is hematologic spread to involve the lungs, the liver, and the other abdominal structures. Now, this is just a brief overview or a brief pictorial representation of the different stages of cervical cancer. And as this is not an oncology presentation, it's just really to show that there are 4 stages. The earliest is where the cancer cells are limited just to the cervical cells, and not just to the cervical cells. It's really to a small portion of the cervical cells and not including anywhere else in the genitalia, whereas stage 4, you have spread that has gone to other pelvic organs or to other organs. And these are the options for management. You may have conization of the cervix, which is really literally cutting out a cone of the cervix, but this is only offered to patients with very early stage cervical cancer. So you're talking stage 1 or stage 1A cervical cancer, where the cells are not visible to the naked eye, and they're limited only to the basement membrane of the cervix. So if you are seeing an obvious mass on the cervix, then this patient would not be a candidate for conization of the cervix. You may also offer complete hysterectomy, or in oncologic terms, a radical hysterectomy, which involves removing the entire uterus, cervix, and tubes. Usually we try to leave the ovaries because ovaries are not generally involved in cervical cancer, but dependent on the spread, and this is usually for patients who have up to stage 2 disease, and the stage 2 means that there is spread down to the upper third of the vagina. And it involves removing most times over 2/3 of the vagina. So you can imagine how morbid that surgery is. And in patients who are not amenable to surgery, they may be referred for chemotherapy. Now, chemotherapy may be administered prior to surgery to shrink the tumor mass, and then an attempt is made at hysterectomy, or in advanced cases, radiotherapy is offered. And I want to point out on this slide that there are patients, again, who are diagnosed in the reproductive age group and may want to preserve their fertility. And this is only going to be possible in patients who have very early stage cervical cancer. And what that would involve is removing the cervix alone, the entire cervix, and the upper part of the vagina sometimes. And so the uterus is preserved, and we call that a trachelectomy. And for those patients, they would need a cerclage at a time of conception or at some point in the pregnancy, as well as abdominal delivery via C-section. All right, and how can you guys help us? Because once a patient is diagnosed with cervical cancer, the patient is most often shipped off to an oncologist or some tertiary institution for further care. But it cannot be underestimated, or it cannot be stressed enough that any approach to the management of cervical cancer will include a multidisciplinary approach. And any approach to the management of any disease that is preventable will be to prevent the disease. And so oftentimes the nurses who are in the peripheral health providing areas are who the patients will meet up on in the first instance, or nurses who go out in the field to do home checks or health checks are who patients will interact with. Once they reach to the doctor, they would have already passed through several other health professionals, including nurses. And so I would say many times the first point of contact is the nurses, and the importance of your contribution cannot be underestimated in the management or the prevention of cervical cancer. And it will start with, before we even get to HPV vaccination, it will start with having frequent targeted discussions with patients to reduce their risk of developing cervical cancer. So discussing with patients the not smoking, monogamous relationship, or the use of condoms, because condoms have been shown to reduce the risk of transmission of the HPV virus. It doesn't completely prevent it, but it reduces the rate of transmission. Discussing with them the timely screening and following up their results, because a lot of patients do the pap smear, but when you ask them what the result is, oh, I never go back to clinic, them never call me, I never follow it up, I forget somebody to follow it up. So those risk changing behaviors are where we really need to start. Also for the vaccination, to recommend that not just for needy women, that we start in our males and females from the age of 9 years old to reduce the risk of transmission subsequently. And even if we miss the passive or the average or the random patient, because a lot of patients are seen in the hospital setting, we want to identify those patients. So we have I'm sure we have what's that? The HIV clinics or so. So those patients who will need yearly pap smears as opposed to every 3-year pap smears, we make sure that as part of their evaluation and assessment and their management, that the pap smear is recommended. We try to push the HPV vaccine. We try to push the HPV testing because we want to have a cumulative effect from the different preventative measures. And so I would say we need to invest in training nurses to have the discussion with the patients regarding the different preventative options, and again have a dedicated team to continue follow up with patients once that discussion has been undertaken. I know we are very short-staffed and we have very limited resources, but again, we can consider home visits for patients who we know have done their pap smears and who have defaulted from follow-up, or we have some sort of follow-up system implemented for the patients to return for their pap smears and have pap smear results and have a review of same, because not only do the pap smear identify abnormal cervical cells, but it can also identify infections in the cervix that may warrant treatment. I know this is done in some health sectors where the nurses perform pap smears. So really it would just be, in addition to performing pap smears, for the nurses to be trained in performing the HPV tests, as well as following up the results of the HPV test and then altering whether or not the patient is to come back in 3 years or 5 years. And then finally, this is just like a Venn diagram, looking at the different ways that we can have input from the nurses to reduce the burden of cervical cancer in our society. So again, health education. So we want to, from the first contact, develop this bond and trust between the patient and the health center with regards to doing the pap smear, getting vaccinated, and getting the HPV test done. Because a lot of times, or I'm sure we've all spoken to a patient who say, oh, I'm afraid to do the pap smear because it's going hot and I'm going to pinch off piece of the cervix, or it going to stretch out my vagina. So a lot of those myths need to be dispelled, and the earliest we can dispel them, I believe, the greater participation from our patients that we will have. And again, on the left-hand side, you see where vaccination, screening, comprehensive care comes in. And subsequently, I believe we will definitely see a change in the incidence, or a reduction in the incidence of cervical cancer diagnosis, as well as abnormal pap smears. So in summary, or finally, because I feel I was told 20 minutes for discussion, let's not let cervical cancer stop us or any other patient. Let us all try to end cervical cancer by getting vaccinated, getting screened, and trying to manage trying to pick up early signs and symptoms, instituting early prevention and treatment, and proper follow-up of our patients who are diagnosed with or who are at risk of cervical cancer. And this is my last slide, I believe, and this is the most recent WHO cervical cancer goal for 2030. And they have a 3-pillar plan. And again, it begins with prevention through vaccination, screening, and then I think this is also where we fall off very badly. Timely treatment and palliative care for invasive cervical cancer. And that is really just because we just do not have the resources in terms of human resource and infrastructure to manage the patients. But again, if we cut down, or if we manage to reduce the incidence of cervical cancer, then number 3 won't be such a burden to our society. So they have this 90-70-90 goal, which is to, let me see if I can make it bigger. For 90% of patients to be fully vaccinated with the HPV vaccine by the age of 15 years. So that means this has to be done in the school system. And then for at least 70% of women to be screened with a high-performing test, which could be the HPV test or the pap smear, but the HPV test has been found to be superior to the pap smear in terms of picking up abnormal cells. And the HPV test is relatively widely available here in Jamaica. It's just that it's more expensive. By 25 years of age, or at least by 45 years of age, and that at least 90% of patients who have been diagnosed with cervical cancer get the timely intervention and treatment of their disease. And that is the end of my presentation. I am happy to receive your questions, comments, feedback. I don't know how to. Hello?
Doctor.
Oh, okay.
I am still here. I am waiting to see if any questions will pop up in our chat. Colleagues, friends, Dr. Sutherland is awaiting your questions that you have. It's a discussion. So let's ask the questions before she leaves. Remember, her time is in demand and short. So let us get to ask the necessary questions that we need answers for.
I see a question. Do you recommend women who are not engaging in sexual intercourse, even up to the age of 30 years old, to do a pap smear? So this was from
I've seen a question, Dr. Sutherland, in the chat. Let me
Yeah,
pull
do you
it up. Give
recommend
me a second.
women who are not engaging in sexual intercourse?
The question is, do you recommend women who are not engaging in sexual intercourse even up to the age of 30 years old to do a pap smear? The question is from C. Wright.
Okay, so remember the HPV vaccine, the HPV virus is transmitted sexually. So once there is no sexual exposure, meaning no vaginal or oral penetration, or no vaginal sex, no oral sex, because remember the HPV virus can infect the oropharyngeal structures, then there will be no reason for the patient to do a pap smear, because we are looking for abnormal cells that occur secondary to HPV infection. The second question is, any treatment for elderly with HPV? I don't understand that question. I'm not sure how to interpret the second question. Any treatment for elderly with HPV? So, Grosset, is it possible for you to expand on the question? Because I don't believe I understand it.
While we wait on her to expound, there is another question asking can cervicitis leads to cancer, from Taylor.
Okay, so cervical cancer occurs due to infection with the HPV virus. So while cervicitis cannot lead to cancer, cervicitis may lead to damage to the cells of the cervix, which increase the chances of becoming infected with the HPV virus, and may increase, especially if the infection is chronic, persistence of cervical cancer virus, which is the HPV virus, which may ultimately lead to cancer.
There is also another question. Could we look into advocating to make the HPV vaccine mandatory in order to meet World Health Organization goal in achieving 90% vaccination rate?
I wouldn't be very optimistic for that one, because the truth is, where cervical cancer is an important infection, it is not a pandemic, it's not an epidemic. So it's not going to be likely that they make it a mandatory vaccine. The most we can do is improve our education of the patients to increase the uptake in the rate of virus. And in the vaccine, increase the uptake in the rate of vaccination, sorry.
And adding to what you just said, I think if we educate people, educate our society as to the importance of vaccination, because Jamaicans on a whole, we tend to be standoffish where vaccination is concerned.
And I don't understand why. I really don't understand why, because the impact that vaccines have had in terms of improving the health status of the world is undisputable. I don't know for something like cervical cancer, which is not even like flu or measles or mumps, it's cancer. I really don't know why people would jumping at the opportunity to get it. When sometimes when I tell patients the cost of the Gardasil 9, they think it's a little prohibitive. I don't know if we can try to reduce the cost, but I think that is just one arm of getting patients sold on the idea of getting the vaccine.
But the cost of the vaccine might be very expensive. However, when we think about the cost for treatment for cancer on a
they
whole,
don't seem to get it. They don't seem to get it. They don't seem to get it. And I think a lot of them think that they won't be the one to develop it. And so they don't see the importance of getting it. The other thing is, remember that most of the vaccines that are administered during childhood, so they don't really have a choice in terms of getting it. When you look at the uptake of adult vaccines, unless it's to travel, we're not really getting it.
so you see the problem lies with educating our parents or mothers, because as you say, it starts at a child age 9. That's when they recommend.
Only for
girls. So at that stage, the parents are responsible for the vaccine that the kids get. So it is educate. I think our problem, a major problem in this country, is education. And even though the information is out there, is like they're not understanding the information that is there. So if education is our biggest problem.
I must commend the Ministry of Health, because I feel like they have put out quite a bit of effort to do national advertising for pap smears and screening and stuff like that. But it's just that our society has not been receptive, and it's not just in Jamaica. It's a global thing. I find that the more international patients generally have a better health seeking habits, and I guess they have better access to resources, so they are more likely to get vaccinated, follow up the pap smear, etc.
All right, so Grasset has expounded on our question. She said, elderly females that are newly diagnosed with HPV, are there any treatments available for them? Families that seem to me 55 or 65 and older.
Okay, but if you have a positive HPV test and you have an abnormal pap smear, or if you have a positive HPV test, then you move on to colposcopy, which is examining the cervix under a microscope to identify abnormal cells, getting the biopsy, and then getting the cells. So the next step, if you're diagnosed with HPV after 30, is possibly or very likely colposcopy and biopsy.
Okay. Another question.
That wasn't a question. That's just a statement.
Oh, yes, a statement.
Yeah.
Are there any other questions, colleagues? We are wrapping up, folks. Do we have any questions? Grasset says thank you.
You're welcome, and thanks for listening.
All right, if there are no more questions, let me just check. Not seeing any other question. Dr. Sutherland, on behalf of the Jamaica Enrolled Nurses Association, we would like to extend a vote of thanks. Thanks for taking the time out on your very busy schedule to give us informative, educational, and timely presentation. I have learned a few things because I didn't remember. I know I learned it in school, but I didn't remember that you start vaccination for HPV at age 9. So it was very informative for me. Really appreciate it, and I look forward to any other presentation with you. I hope you continue to be a part of this family, a part of this group. Thanks for joining us today.
Thanks for having me.
Have a good afternoon.
You too. Thank you.
Pleasure.
Okay, bye.
Bye-bye. All right, ladies and gentlemen, colleagues, visitors, I'm just going to hand over to Madam President, who is going to close us out. I want to say thank you guys for spending the day with us. It was very informative, very educational. Be reminded, in order for you to get CMEs, you have to complete the registration form. And the next event for the year from the Jamaica Enrolled Nurses Association is Health Fair, June 21st. All road lead to Maypen. Toll Back Road, all road lead to Maypen. So we'll see you there. Do have yourself a productive afternoon. Thank you for spending the entire day with us. We really appreciate it. Happy Nurses Day again. You're so right, Samson. What a very informative session today. Very informative, very timely, especially Ms. Nelson's presentation, this presentation on cervical cancer, because we are mindful that yes, certain diseases exist, but we keep it at the back of our mind, but we have to remember health and education is very important. So remember to get your regular checkup with your gynecologist, guys. Let us not forget to take our health. I'm going to hand you over to our president, Madam Clark. Do have a good afternoon. Thanks for having me. Do enjoy the rest of your week.
Good afternoon again, colleagues. What a day it was. And I want to thank you for being here, even though we have gone over the time that we were supposed to stop at 4, but we have gone over 4 o'clock. But I want to thank you guys for staying in tune. And just to remind you that your CME hours, they will be emailed to you. And also, at this time, I just want to express my sincere gratitude to the Director of Nursing Services, to which my secretariat belongs, because I don't have words to say to the DNS, Director of Nursing Services, because you have allowed the team to be here with me for the entire week, and I am grateful to you. And just to pinpoint out, UWI University of the Hospital, Spanish Town Hospital, Mandeville Regional Hospital. I am very grateful to you, DNSs, and I am humbled at your feet. Thank you. Let me say thank you too to the offices of the Nursing and Midwifery Services units at the Ministry of Health, which is led by our lovely Chief Nurse, Mrs. Patricia Ingram Martin, and our Deputy Director, or Deputy Chief Nurse, Mrs. Juliet Mason Corey. Thank you guys. God bless you. And big thanks to my administrative staff here at the office, Ms. Jeffrey, Mr. Gordon, and also to our assistant treasurer, Mr. Shaw, and Mr. Alan Jeffrey, our treasurer. We really thank you. To Joy Chapman, our secretary, we thank you for being here. Thank you guys. Thank you for making this day the success it has been. God bless you. Do have a good rest of the evening.